Good afternoon, everybody, and welcome to this final session of IMPACT HTA. I'm delighted to be here to celebrate the conclusion of this programme, and I hope that by the end of the afternoon, you too will agree that there is a great deal to celebrate. I can see that so far we've got 64 participants on the call, but I am expecting more to join us. So IMPACT HTA commenced in January 2018 with funding from the European Union's Horizon 2020 Research and Innovation Programme, and you can find full information on the programme on the IMPACT HTA website. There are three key objectives to the programme: understanding variations in costs and health outcomes within and across countries, assisting decision-making by developing innovative methodologies, toolkits and processes, and facilitating EU-wide cross-country collaboration across member state governments, HTA agencies, professionals, and the broader stakeholder community. The programme had 10 research areas, and we will hear today the top-line results from each of those research areas. We have 3.5 years of work to cover this afternoon, and we don't have that many hours to do it. So our focus is going to be on the potential impact of the results on HTA agencies, researchers, policymakers, governments, patients, and other stakeholders. Each work package has 8 minutes to present their results, and the invited commentators have 7 minutes to address the practical relevance of the research findings. I shall be ensuring people keep to time. My professor taught me many years ago that it was disrespectful to take someone else's time by you running over. So I've kept that with me all my working life. I will give a 1-minute warning to speakers and to commentators if it looks as though you're not likely to close on time. All presentations and a recording of this session will be available on the HTA Impact website. During the course of the session, please post any questions using the chat function, which the work package leaders will be able to respond to directly, and hold more general questions until the end when we have a discussion section. You can always contact the work package leaders after this afternoon session if you've got specific questions that you want to ask them about their work. Panos, I'm going to hand over to you now to provide some context and more general introduction, and I look forward to a very exciting afternoon.
Thank you very much, Jean, and excellent introduction. I trust that you will keep to time. You will keep us to time. Delighted to be able to see this project to a successful conclusion. I just wanted to, once you're seeing the second part of the agenda for the session this afternoon, I just wanted to say a couple of words about IMPACT HTA. The origins of the IMPACT HTA Consortium, as you will see it in a minute, and as you see it on the slides and the work to be presented, date as far back as spring 2016. In other words, just over 5 years ago, when some of the what subsequently became the IMPACT HTA Consortium, some of us got together in London to discuss potential collaboration in the field of HTA, knowing that there is a significant agenda to be addressed from a research, but also from an empirical and a policy perspective. We subsequently applied for funding. In 2017, we were successful. In April 2017, and we were successful 6 months later when we got the notification from the European Commission. As Jean mentioned, the project started in January 2018. Jean, you very nicely introduced the key objectives. You can see the objectives of the IMPACT HTA project. IMPACT HTA set out to explore improvements in methods, tools, and guidance for decision makers. So we have we did have, and we still have, and we will have a keen interest in research, but also the empirical application and uptake of that research. So we were and we are keen to see our work being empirically applied by the decision-making community. So, understanding therefore variations in cost and outcomes within and across countries, integrating clinical and economic data to improve from different sources to improve methods, a significant gap therefore, addressing a significant gap therefore in health technology assessment, but also developing a number of tools, innovative methods, but also processes and guidance aiming to facilitate decision making. And at the heart of all this, we're also seeking, we were and we still are seeking to promote collaboration amongst our institutions, the research community, and obviously the decision makers. The IMPACT HTA Consortium seeks to address or sought to address 10 thematic areas. One related to the combination of RCT data and real-world evidence information data, the issue of healthcare costs and social care costs and the comparability across settings by creating methodologies that allow us to compare costs, healthcare costs, but also social care costs across settings, preference-based health related quality of life, methodologies to deal with non-randomized data, hospital-based assessments, multi-criteria value methods, the measurement of fiscal impact in health technology assessment, the appraisal of orphan medicinal products, and incorporating behavioral aspects in HTA implementation. So a very rich agenda across the board, hopefully addressing significant gaps that decision makers did have at the time, and we hope that some of this work is going to be of practical relevance and importance to both researchers but also healthcare decision makers. Here you see the IMPACT HTA Consortium comprising 15 organizations across the European Union member states, and we've been fortunate enough to be collaborating with universities, providers, but also health technology assessment agencies. In other words, a fusion of stakeholders who are named participants and partners in this consortium. Of course, it should be borne in mind. We should bear in mind that the broader stakeholder community has been represented in terms of consultations, both formal and informal, but also inclusion of the broader stakeholder community, particularly the patient, the carer community, the private sector, insurance in our discussions, in our workshops, but also in individual work package. Here you see the principal investigators or work package leaders from each organization, from each institution, but obviously there is a large number of researchers who have contributed papers, workshops, and an input in the project. Personally, I owe an enormous debt of gratitude to all of you, and it's been a very fruitful collaboration over the past 3.5 years, and I'm delighted to be able to present to the broader community the results of our effort. I think collectively we should be proud. Jane, back to you.
Thank you, panelists. Keeping to time, excellent start for us. So I'm now going to call on Ali Maguire and Jaime Caro to present the results of the first work package, please.
Thank you. I'm going to share my slides now. Hi, I'm Jaime Caro. Good afternoon. On behalf of my colleague Ali Maguire at LSE and Bash Naidu at NICE, I'm happy to present the final workshop for Work Package 2. The deliverables for this work package were a review of the methods used to extrapolate randomized clinical trial outcomes using real-world data, validation of the DICE modeling technique, and particularly speeding up and facilitating execution of the DICE simulation macro, and then producing training modules and manuals for HTA staff, reviewers, and modelers. And I'm happy to say that we've completed all 3 of these deliverables, and actually more than that. For the workshop, I'll just focus on the second deliverable, the updating and progression of the DICE modeling technique. Very briefly, the core of a DICE model is about forecasting For each contemplated intervention, a decision maker wants to know, given the conditions at the time of the decision, what will happen to these and when these events will occur. So we have a set of conditions. They may pertain to the patient, to the values of the patient and family and the system, and to other valuations like the societal perspective and so on. And these things may be changing over time, so they're dynamic. So they're going to be modeled or forecast out over time until some end event. And the changes happen at what we call events. Events can be about the treatment, for example, about hospitalizations or real world events, or they can be model-specific events like the transition event in a Markov model. The DICE model is specified in very simple tables or lists. Here is a conditions list for a partition model, a survival partition model. You have the name of the condition and its initial value. Then you have a list of the events with the name of the event, when it starts, and what the name of the table is that contains its consequences. Oops. There we go. The consequences are listed in their own table for each of the events. And then we have a list of the outputs that we want to accumulate. Two other important lists are the patient profiles that we're going to simulate and the interventions and their details. So a DICE model works in the following way. When you press the run button, it sets up a bunch of counters. Then it reads the profiles, reads the conditions, reads the events, and then it begins the simulation by finding the first event that it needs to run, executes the expressions for that event, asks whether an end event has been reached. If not, it continues that for loop until an end event is reached, at which point it begins asking, do I need another intervention? If so, go back and do it again for the next intervention. If not, do I need another profile? If yes, then read the next profile and do the whole thing again. If not, do I need another replication because I'm doing, for example, probabilistic sensitivity analysis? If yes, increase the replication number counter and repeat the whole process. If no, are there any scenarios that I need to simulate? If yes, go ahead and simulate the scenarios. If no, you've finally done and you can report the raw results. And so you do this out over time for as many replications, profiles, interventions that you need to model. There are several engines available in R, VB.NET, and Python, but we focused on the Excel engine because it's the most readily available software. It's easy for everybody to use, and the health technology assessment agencies can easily work with it. The validation consisted of taking several models that NICE had already built in the traditional method. Here is the main one that has been published, which was a breast cancer chemoprevention model. They had originally built a standard cohort Markov model, which in fact was 32 Markov models, because it needed to handle 4 strategies, 4 age strata, and 2 risk groups. Several additional features of that model were that it handled patient non-persistence, mandated treatment stops, and end of adverse effect risks. And they did that by creating additional states and many, many formulas, tens of thousands of formulas. Not surprisingly, this ended up in 2 very large files totaling 17 megabytes. Implementation took them at least 18 weeks. And in the DICE approach, we completed the same model with 1 intervention variable for the strategies, 8 profiles for the age and risk strata, and 3 conditions for the states. We handled everything via 3 events set to occur at appropriate times. And this resulted in a tiny file of 116 kilobytes. And the implementation took less than 1 week. And it gave exactly the same results, showing us that this was indeed an efficient, valid method. So in conclusion then, DICE is a simulation method that facilitates health technology assessment. You can build cohort Markov models, microsimulations, that's individual Markov models, survival partition, discrete event simulation. And the last pink circle is our most recent model, which we completed for the Guy and St. Thomas Trust in London, which is an SEIR model of the COVID pandemic as it applies in that area of London. This has now been extended to more than 1,500 locations around the world. So we're producing specific estimates for each location on a weekly basis, including also resource use that will be required, ICU, occupancy, and so on. So a DICE model then is specified in a text blueprint that lists all the various components that we've talked about. You implement it in a simple Excel worksheet in tables. And this makes it very, very transparent, very flexible, easy to use. And then you execute it using a simple Visual Basic macro that reads the lists, carries out the instructions. This engine is completely free to download and is posted now on the IMPACT website, and it's updated on a regular basis. You don't need any special software, just Microsoft Excel is fine. And there are other engines, but you don't have to use them. They are faster, that's their main advantage. So the next steps for this work are to continue to improve the engine. We have a moderately long list of moderately long wish list with things that people have requested be added to the engine. We are continuing our training of HTA agencies and modelers, and this has been quite successful at many of the European agencies and elsewhere. And there are still a number of publications that we're going through the process of finalizing and getting them submitted. These are our contact information, and thank you very much.
Thank you very much, Jaime. That was impressively kept to time with a lot of information delivered and beautifully clearly as you went. So could I now call on Salah Gabri from IHTA to commentate on this piece of work, please?
Yes. Yes, thank you very much. I'm Salah Gabri, Senior Researcher of Health Economics and Economic Evaluations and Coordinator of Scientific Project at the French National Authority for Health. And I would like to make two comments about the use of DICE approaches and ask finally some questions to Jaime Caro. First of all, I think that today the added value of the DICE approach is recognized in the literature by health technology assessment agencies, because DICE provides a new way of modeling and intuitive concepts. For example, with the dynamic and the statistic conditions, these definitions are simple for modelers, for clinicians to understand the clinical significations. And of course, consequently, there are advantages for healthcare decisions in terms of flexible and transparent process, as described Jaime, and especially to implement the modeling of treatment of sequences based on randomized clinical trials, network meta-analysis, and real-world data. I can mention a very interesting example about a complex project of economic evaluations performed by the National Health, by the French National Authority for Health, about the economic evaluation of sequences of biological treatments for patients with moderate to severe rheumatoid arthritis and inadequate responses or intolerance to methotrexate in France. The modeling is very interesting, and we have the chance to include more than 100 sequences of biological treatment, and this work was published recently in Value in Health as economic evaluation of healthcare decision makers. The second point of my comments is about the DICE perspective and challenges. I think that Jaime and his team should continue to diffuse the DICE culture, because today the approach of modeling of DICE is understood sometimes as a tool of modeling, or DICE is an approach of modeling. DICE is an approach that can be added to the decision tree, Markov, discrete event simulation models. So there is a work is needed to diffuse this culture of DICE approach among healthcare decision makers. There is also another point about the perspective and challenges is about the inclusions of transmissions and vaccine models. Today, health technology agency do not ask for modeling of COVID-19 vaccines, and healthcare decision makers made political arbitrary decisions. But I think the question will arise in the next years. So DICE should develop and include, for example, mathematical framework for dynamic decision analytic models. It's usually the question asked by academic health technology reviewers of submissions of manufacturers. And finally, I would like to ask two series of questions. The first question is a technical questions, and with Jaime Caro, we had performed sensibility analysis on the complex project in about biological treatments, and we have some issues about the use of probabilistic sensitivity analysis. So my question is, are the times required to perform PSI using Monte Carlo simulations improved in the current version of DICE? And the second and final series of questions, beyond the economic modeling of health technology, is it possible to develop DICE for topics related to COVID-19 and link it with epidemiological models? The first question. And the second, is it possible to develop DICE for public health economic HTA? For example, include parameters related to inequality, distributional cost effectiveness models, extended cost effectiveness models, and why not to include also the process of deliberative methods, like, for example, multiple criteria decision analysis. So again, thank you, Jaime, for this excellent presentation and the added value of DICE in the literature of economic modeling. Thank you very much.
So Jaime, we've got a couple of minutes if you can answer those questions quickly. If not, you might want to give an indication of the answer and then have an ongoing communication afterwards.
Sure. Thank you, Salah. That was a very nice and crisp commentary. The answer to your questions, fortunately, is straightforward. So the speed has increased 45-fold since we began the project. So the engine now runs 45 times faster, and we are continuing to find ways to increase it. We do have the C# engine, which runs 1,500 times faster. So if you really have a big analysis, then you can use the C# engine. Regarding COVID-19 modeling, I briefly mentioned that we completed a project for GSTT, the Guy St. Thomas Trust. We are modeling extensively, including the SCIR component. Across the world, we've modeled 3 of the vaccines, modeling treatments, etc. So yes, very much, with the one limitation that we cannot at the moment do agent-based simulation. So that is not in the DICE purview at the moment. We're thinking about ways to do it, but the runtimes would become impossible in Excel. So we would have to abandon Excel. Public health economics, an extremely interesting topic. I haven't really thought about that. Thank you for the question. I think the answer is a tentative yes, but I would have to think more about how you conceptualize these public aspects and how you can express them in a way that DICE can understand them. And again, thank you.
Okay, thank you very much. Has that answered your questions?
Thank you.
Excellent. Well, I can't believe we're actually running a couple of minutes ahead of time, down to Jaime getting us off to a really good start. So I'm going to move on now and ask Susanna and Joanne to present their results.
Good afternoon. Can you see my presentation?
No. I've got something very strange on my screen. I don't know whether everybody else is seeing it normally.
Same here.
Now I can see it properly, yes.
Yes? Okay.
Yep.
So the idea behind our project, Work Package 3, is that cost elements are one of the critical factors for the transferability of the results of economic evaluations. And so reusing study results would save a lot of time and thus avoid wasting resources. In order to be the economic evaluation study of a certain technology carried out in one country, reusable and transferable to other countries, it is necessary to know what resources are included in the cost calculation. So our objective was to develop an easily accessible and usable minimum common dataset of international costs. Regarding methodology, there were several steps. The first step consisted of literature review, in order to know what elements should contain our database and also what costing items are the most used in economic evaluation. The second step was communication with project partners who validated our database and provided us with links to costing documents used in their countries. The first step consisted of analysis of costing documents and searching for the unit costs. And also we started to introduce.
Susanna, there's a question in the chat. Could you please switch to full screen presentation mode? I don't know whether you're able to do that. I think it would be easier to read.
I see, but I see it properly, you know?
Well, we can see a separate screen on the right with what I think is the next slide.
You're in presentation mode. If you swap, go to slideshow on your menu and just swap it.
Thank you, Jaime, beyond my technical capability.
I'm not sure where to do this.
Hit escape.
Yeah.
Just escape from your presentation quickly.
Yes.
There. Now go to slideshow, presentación con diapositivas.
Now?
The menu, no.
No.
You have to, what's happening is that your monitor is showing the actual presentation and what you're showing us is the speaker's view. You need to swap them. Go to opciones de presentación at the top left. Yeah, pick that, click there. Cambiar la vista del moderador y de la presentación. There you go.
See now?
That's better. That's ideal. Great.
Okay, so I was here in the final step of our methodology, which consisted of validation of costing methodology and unit costs by project partners. The first output of our work was consisted of 27 costing items organized in 3 main categories and 13 subcategories, and this combination of this gave results to 104,040 unit costs. And each item contains information on these characteristics here in yellow. And we could say that one of the outstanding characteristics of the database is that it can update automatically costs using GDP deflector and also consumer price index using the last value available. The second result is costing methodology, and here in this screen you can see elements that hamper cost comparison across countries. Regarding primary resources, they are a variety of existing brands and or models, also difference in monetary values placed on medical devices and health products, such as ex-monetary price, reference price, and so on. Some of these unit costs include value-added tax, others excluded, and internal personal costs, elements that hamper cost comparison that are included in some countries but excluded in others are such as travel, qualifications, worker seniority that is included in Italy but not in other countries, labor union negotiations, etc. Regarding composite goods and services, in England, all of them are based on DRGs, but in Italy, Portugal, Spain, and Sweden, none of them. Then we could also see that publicly available costing documents were often missing. And here I put 3 examples. The first one represents outpatient visits, and the cost in countries depends on who is this outpatient visit led by, where it is performed, whether in a hospital, in outpatient clinic, a patient home, type of specialist, unit of measurement, and so on. Regarding complex services and interventions, they are organized in DRGs in all countries, and they have may attributed costs or tariffs or both. For example, in England and France, all of them have costs and tariffs. Most direct costs and variable overheads are included in costing items of all countries, except in Germany, where nursing costs are financed in a separate way. And the main issues here are fixed overheads, such as teaching costs, research costs, depreciation of building, and financial costs, because they are included in DRGs in some countries, but not in others. And now my colleague Joan Rovira will talk about future development.
Yes, thank you. Actually, the conclusions and the what next part is what I am going to briefly develop. So our study has shown us that there is a high level of methodological heterogeneity across few countries, at least the ones that have worked with us, in defining the resources. And although the name sometimes seems the same, then what is within some resource item is not the same in 2 countries. And also in relation to the respective monetary values and the methodologies for estimating the cost or the money values. There is, moreover, a lack of transparency in the sources of cost information and the accounting methods used. This situation, in fact, limits the comparability of healthcare costs across the countries, and also limits the transferability of one study done in one country to other countries or settings or jurisdictions by changing the respective values, the monetary values, at least so far. This is something that we had in mind when we developed this work package, and is what our deliverables, our products try to address, together with work package 4, which makes a similar approach that they will develop as for the social cost. So what we are trying is to intend to overcome these limitations, to enhance cross-border collaboration in economic evaluation of health interventions. So we tried to build good knowledge of the methodological foundation of the existing data sources, and we also provided a kind of practical initial version of the international units cost database with now it's 27 items, but can grow. So we propose in the next paragraphs. These ideally 27 items is not much. Everyone having done some economic evaluation knows that they need for probably from 20, 50 or 100 sometimes different resource items to use in the model. So actually as it is just a tool to prove that it works and it's robust, etc. So apart from having a database with as many and as updated as possible items, we think that the second a second product would be to have for each country, if they like, to have it a kind of standard cost list. As some countries, for instance, Australia, they have this for many years, which is a kind of byproduct or a kind of additional product that can further facilitate the transferability of economic evaluation across countries and opportunities for cross-border research, for instance, in the terms of multi-country studies using a kind of basic biological clinical model. We think that these tasks should be part of the what next question. So we think in terms of a kind of future international consortium, which should of course be open to all participants of HTA Impact, the ones that have been essentially providing us with the required information on cost and costing methodologies in their countries. And we want to acknowledge once more their essential collaboration. But I think we should open this to other interested parties, for instance, the members of the Pecunia project, which has been running in parallel to us, and also to already existing national organizations involved in haircut costings in the EU and basically elsewhere. I think this has not to be limited to EU, because sometimes one is interested in bringing to your country a model or a study done in another country outside Europe. So basically this database could in the future also be extended to additional countries. That's all.
Lovely, thank you very much, Susanna and Joanne. And I think now we have comments from Inaka and Francesc, please. Do we? Do we have Inaka or Francesc available to comment? Hala, do you have any clue as to whether we're having this commentators?
I think the best is to ask John and Susanna if they confirmed with the commentator.
No, it doesn't look as though Joanne or Susanna, do you know, have confirmation that your commentators are going to be here?
Well, I think so, but it was Jaime that contacted them. So what I can do is I can call them, but maybe it would be better to go on, and then maybe if they have a problem with the time, because actually the time was in UK time, no? And probably I did a mistake, so I came earlier.
You had the problem, yeah. Okay.
So maybe someone else has done the same problem. So I will call.
Yeah, but they were contacted, so I don't know why they are not here.
Okay, I don't think we can wait for them. we had one question which was about how do you plan to update the database. I don't know whether you want to make any comments specifically about that, either of you, before we move on.
Well, actually, as I told in my conclusions, the idea was to update them regularly, because you cannot use this forever and just using
define regularly, Joan.
Well, I had some experience with the Spanish database of unit cost, and then we used to update them each year. So we make a literature survey, and this was enough, no? Because then you can also extrapolate using the some kind of price index, the monetary values to 1 or 2 years, and this is acceptable. But of course, if you have a 10 years old observation, it's very unlikely to be accepted, you know, kind of statistical extrapolation. But we don't have a kind of proposal, a final proposal on how to update. It will depend on how we go on with this initiative.
Great. Panos, you wanted to comment?
If I can interject, yeah, I think what is important to highlight, as Susanna and John mentioned, I think it's important that we have a process and a method. So I think the deliverable is there, and a sample of interventions for which we have collected the data from a number of European countries. Obviously, the extension, the expansion, and the continuation, if you will, the sustainability of this is subject to further funding going forward from a variety of sources. And there may be either through the regular channels that we have applied to so far already through the IMPACT HTA Consortium, or other channels that may have an in seeing this continuing. I think it will be a great idea to see that continuing, obviously with the cross project collaborations that Jean alluded to earlier on, Pecunia and so on. I think there's a great potential there. In order to ensure that we have some kind of meaningful metric to ensure some kind of comparability when we conduct economic studies across settings within the European context. But I wanted to highlight the importance of having a method and a process based on which we will collect information and data. Thanks.
Okay, thank you. I don't see any other chat you need to respond.
Can I just, if there is an opportunity, since we are a little bit ahead of schedule, if one of the commentators arrives later on, and if there's an issue with timing, we might be able to fit them at a later stage, if you agree. But yeah, we are slightly ahead of schedule.
Yeah, my plan is that if we keep moving as we are, then we'll have more time for discussion at the end, and hopefully they might be able to join us at that point. That would be my wish anyway.
Excellent.
Okay, so if we could move on to the next work package, please. And I've got Lutz Maria going to present on this. Oh, there you are. That's good.
Yeah. So can you see my presentation?
Yes.
Yeah, okay.
Yeah,
so,
perfect.
Good afternoon, everybody. Thank you so much for giving us the opportunity to present our results and our impact of our work package number 4. It's basically based on the social costs and the role in the economics evaluation for healthcare making decisions. I'm going to present it on behalf of the University of Castilla-La Mancha team. So in brief, this work package is divided in 3 different objectives that led to 3 different tasks. The first objective was related to determine what wider effects, meaning wider effects that application of the societal perspective need to be measured in the context of economics evaluations. So to achieve this objective, we perform a narrative and analytical report in which we revise the methodological aspects related to the identifications, the measurements, and the evaluation of social costs in the economics evaluation. When we talk about social costs, we refer to the labor productivity losses and the informal caregiving cost. So the second objective was related to identify how such wider effects, I mean the application of the societal perspective in the economics evaluation, might change or not the conclusions and the recommendation and the result of the economics evaluations. And we performed several systematic review using Medline plus tabs in 5 different diseases: in Alzheimer's disease, rare disease, diabetes, depressions, and multiple sclerosis. And the last objective of our work package was to produce a website, a data set, providing information related to the unit costs that are needed when analyzing or when evaluating social costs. Well, for example, all the unit costs needed to analyze labor productivity losses are provided in this website. And also all the unit costs needed when analyzing the informal caregiving costs are also provided in this website, and also the unit costs related to the formal services. And we consider several European countries for these working packets. So this task was done jointly with working package number 3, and it's the same, but we focus on social costs and they focus on healthcare costs. So what were our main results? So the results can be divided depending on the tax. So for example, in tax number 1, we performed this report, and the main conclusions related to the methodological aspect of the labor productivity losses were that the debate about whether human capital approach or friction cost method is preferred when estimating labor productivity losses is still far from being over. And regarding to the methodological aspects related to informal caregiving costs, we conclude that the opportunity cost methods is the most common approach when economics evaluation are performed or in cause of illness studies. So related to tax number 3, the website, this is the website that provides information on the unit cost. This is the address. And in general, here we provide information of unit costs, all of them adjusted by inflation rate and currency. And we use information of exchange rates and also official site depending on the country. But all the information related to the unit costs that are needed to value labor productivity losses, informal caregiving, and formal services in different European countries are provided here in this data set. And related to the results in tax number 2, we published several publications in different scientific journals. And the main conclusion, or the general conclusion, was that the inclusion of the societal perspective might change the result, the recommendations, and the conclusion of the economics evaluations. But these figures depends on the disease considered. For example, there are some diseases in which the changes in this economics evaluation are higher, around 30% of the economics evaluation considered. However, there are others in which the changes in the conclusions and the result of economics evaluation, when the social perspective is included, change less, around 80% of the economics evaluation. So the inclusion of the social perspective might change the result and the recommendation of the economics evaluation, but these results depends on the disease considered. So to conclude, what are the main impact and the future agenda that we can obtain from the information and the results obtained from our work packets? So the first one is that it's important to increase the consideration of the societal perspective in the economics evaluations. And more precisely, it's very important to advance in a greater methodological homogeneity, as they mentioned in the work packets before, when economics evaluation are performed. And also it's quite important to promote the inclusion of the spillover effects on health of family members when caregiving costs are included in an intervention. And also it's quite cute to perform a general strategy to improve the access to the data sources when estimating social costs in terms of the identification and of the measure of such social services. And finally, those countries that recommend the consideration of the social perspective in their guidelines should also promote the application of such societal perspective in the economics evaluation. So it's not only to recommend the application of the social perspective, but it's also to promote, to incentivize resources to apply this societal perspective. But as I mentioned before, the inclusion of such societal perspective might change the recommendation and the result of some economics evaluation performed. So that's all for our work packet. Thank you very much for your attention. And we are looking forward to hearing the contributions and the comment of the two experts that are going to comment this information. So thank you very much in advance, Professor Marta Trapero and David Stein.
Thank you very much for that very interesting presentation. I know from multiple conversations with Julio over the years that you will be taking those results to patient organizations because they will have a particular interest in that perspective being incorporated into health technology assessment. And, you know, if I can help in any way there, Julio, just let me know. So, as you said, your commentators, I hope, are standing ready. I've got Marta, I can see, and David. So over to you two, please.
Okay, David, if you don't mind, I can start. So thank you very much to all the researchers that have been contributing to this amazing project. Is really, I mean, looking at the menu is really touching key topics around economic evaluation. So my first congratulations to all of you. And especially to the work package that I'm going to be just commenting on, because having 4 papers before presenting the final session of an European project published, this is a huge merit. I've been participating in European projects, and this is difficult. Yeah, so congratulations on this for publishing your results. I have a couple of comments regarding your work package, and are about reflections. And I was reading some comments that Ayla was doing in the chat, and I was thinking the same. You have been kind of measuring or trying to measure the social cost on healthcare, yeah, and the social perspective. But I always wonder if we are really doing that appropriately in the healthcare field. I mean, obviously, I will be doing the same, you know, reviewing the literature and how we have been incorporating the social perspective in the healthcare. But I always wonder if we can learn from other disciplines, environment, transport. And if you look how they measure this social kind of cost or the social perspective, they are very good, especially environment and transport, to incorporate the suffering or anxiety or pain around the social perspective. So I'm wondering if we should, if the research shouldn't be kind of, you know, moving towards exploring if the definition that we are using a social perspective, because to me, social perspective is, you know, everyone, and we always incorporate family and carers, which I'm not saying that it's not correct, but I think that we could be missing something, right? So this is my first comment. This is not a critique, is something to make a reflection on, yeah, in general. And then another point that I really found very interesting coming out from your results is that you were stating that the evidence on the methodological aspect related to patients' non-paid time is very scarce. And this is also something to claim our attention, because we are living surrounded of, you know, a very scarce resource, which is time. Not only money. I will say that now time is more scarce than money, at least in our context. And I think that we should be, you know, doing an effort to measure and quantify in a monetary way this scarce resource that it's time and non-paid time. Yeah. Another comment that I would like to ask to you, that I imagine that you already have think through, but I think that it's interesting. You already have done quite a lot of work on calculating if there are differences between societal and non-societal perspective in different diseases. Yeah, but when we need to then kind of move on towards the policy implications, I was wondering if you have thought about a grouping, a kind of grouping or a kind of pooling different kind of characteristics of these different diseases, because, you know, this is very time consuming. We cannot really calculate, you know, if there are differences among all the different kind of existing diseases or pathologies or whatever. And I was wondering if you have thought through this, if there are some common characteristics that we could kind of generalize a little bit more these important conclusions. And I think that I will just give pass to David. Obviously, we need to keep working towards this direction to answer the question, the important question that it's when it's really important to include social perspective when we need to take decisions on health technology assessments, and when we are really on the table taking those decisions. Thank you very much and congratulations.
David.
Hi. Hello. Yeah. Yeah, just as Marta said, I'd like to reiterate the same point, that congratulations to all the team for a fantastic scientific production and interesting papers that have been already published, and I expect more on the way. And the same as Marta, perhaps my discussion I might want to think about the why we include social costs as much as the how, which I think most of the papers that you present, that you showed, focus on the how. But what are the social costs? What are the social costs of including social costs? What are the benefits and disadvantages of such a policy, if that's what we want to do? What does it, if we did include social costs, what does this signal about the kind of health service that we are striving for? Who is that health service for, and what are its objectives and priorities? And traditionally in economic evaluation, I think there's been quite what you might call the health service perspective has quite a simple set of variables. The aim is to maximize the health of the population, usually expressed by the QALY or something similar, given the limited resources available, and that's expressed as health service expenditure. And then researchers can then investigate or estimate the supply side threshold, for example, £13,000 per QALY estimated by Claxton in England, or £22,000 per QALY estimated by Vallejo Torres in Spain. And that is calculated from this perspective, from this simple but bivariate perspective of QALYs and expenditure. Now, if we include social costs, well, they're normally excluded because they don't contribute either to the maximum, that is patient health, nor are they part of the constraint NHS expenditure. But the argument goes, then they're not relevant because they're not part of that calculation of the threshold. And in this project, then and others that have the same kind of ambition, ask, should social costs be included in economic evaluation? And this project has shown that the results can be quite different, and especially in diseases like Alzheimer's, which are absolutely devastating for the families as much as the patients, and forcing family members to drop out of the labour force and to spend heavily out of their own resources in order to care for the patient. If we accept that those social costs should be included, we are in fact planting very different objectives for the health service. So no longer are we just assuming that the health service is there to maximise patient health. We are suggesting that it should be a vehicle for supporting other ambitions of society, especially paid employment, productivity, economic activity in the wider sense, supporting unpaid carers and so on. So including social costs in economic evaluation formalises that idea that health service should pivot away from clinical outcomes and prioritise instead, because there's always an opportunity cost, prioritise instead treatments that support patients in paid employment and support families who have dropped out of the labour force to be carers. So therefore we should pivot away. This has important implications for age inequality, gender inequality, and social economic inequality, because we're going to pivot. If we include social costs, we will pivot away from services orientated at improving life expectancy and quality of life in the elderly and retired, and towards those that get working age patients up and running and working age carers back into the labour force. And given that the majority of carers are women, this is going to have important knock-on effects for gender inequalities that need to be carefully thought through. Given that the human capital approach and similar approaches define productivity in terms of earnings, this will have important and often uncomfortable implications for social economic inequalities. And these knock-on effects need to be carefully thought through and carefully studied before we suggest that we include social costs or not. So I think society should be having this debate. I think the COVID crisis has thrown into the limelight the importance of the health service as a social pillar, but the debate will not be a comfortable one, because for every service that we prioritise, we must deprioritise, if you like, other services, and that will have implications for inequalities.
Thank you very much. I don't think we have the time for Julio and Luz Marie to answer all the questions that have been posed during your two commentaries. Very interesting commentaries, and I think, I will pick up with Panos at the end. Julio, Luz Maria, did you want to make any quick response?
Yeah, first of all, thank you so much for both of you for your commentation. All of them are very interesting, and just very, very, very quickly, it's true that we found a lot of heterogeneity in the application of the societal perspective. So according to Professor Marta Trapero said, it's true that maybe to find this homogeneity in the application of the societal perspective, maybe we should look at other areas when applying this perspective, just to learn something about them, and just to find this homogeneity in the way of application of the societal perspective. And related to if we thought about the grouping characteristics just to study the systematic review, the thing is that we thought about the chronic disease that have a high prevalence. And we thought about this disease, another disease that we didn't have enough time to perform before the project finished. But it's true that we should stop thinking about how we can continue to this analyze, just to continue to explore other areas, and to think about it if it's necessary to group in some characteristic of some disease, just to get the results, just to extrapolate to the general. And I don't know if you have more time, so thank you so much for both of you for your comment and for having accepted to participate in this workshop.
Yeah, I would like to say, Marta and David, thank you very much. And I will say also that we have been working a lot with Alzheimer's disease and orphan diseases, and the informal care and the productivity cost losses are incredible in these two areas. We did the Burkwall project, and even the commission with the orphan diseases were surprised for the cost of the informal care for all these illnesses and the productivity losses. And I wouldn't say anything about Alzheimer because just the cost of the Alzheimer disease in Spain for informal care 10 years ago was 10,000 million euros. So 10 billion euros. So it's impressive. But thank you very much, David and Marta, for your comments.
Thank you. Panos, I just want to make a comment that, what we've heard during this and previous presentations is giving you a huge further research agenda. I do notice, Inaka, we have you joined. We were expecting you to commentate earlier on. May I ask, are you going to be on the call now for the rest of the session? Can I ask you to commentate later? Are you happy with that?
Yeah, I'm happy with that. Yeah. Okay. I'm sorry for not joining before, but I had other commitments and I was unable. There were some comments at the government, so sorry about that.
It's fine, absolutely fine. Okay, we're going to move on now to Wolfgang. If we could hear from you, please, about your research.
Well, I was looking for the mute thing, and now can you see my screen now? Wonderful. So yes, good afternoon, everybody. After all these very interesting presentation, now some core results from work package 5 about health preferences of different subpopulation groups using EQ5D and EQ5DY for younger population. And you see it's also with a number of study groups from different countries. I will come to that later again. Health state preferences are relevant, as you know, for valuation studies of health-related quality of life instruments to develop value sets. They are usually used, for example, for economic evaluation studies, and so they also belong to our topic here. In our project, we compared patient health preferences to general population preferences to explore the need for patient values and possible implication of their use in economic evaluation. And second part, we compared health preferences in adolescents to adult preferences in child health, also to get insight on differences. And third part, we developed 3 EQ5DY value sets in the different countries, as there was a lack of value sets before and therefore limitations regarding cost utility analysis for child and adolescents health interventions. For that, we conducted online surveys using DCE, discrete choice experiments, to ask participants about their preferences for a particular health state, presenting 2 different health states where they had to choose. For the patient surveys, in the column on the left here, diabetes mellitus and rheumatism patients were included. And you can see the overall sample size down here. But notice the number of participants were divided equally between the participating countries, Slovenia, Spain, and Germany, and each of these 3 sub-studies. And now a very short overview about the study results. At first, about the differences between the preferences of patients and the general population. And you see here in both countries, patients gave more importance than the general populations to the dimensions mobility, self-care, and usual activities. These are the functional dimensions, and less importance to the so-called symptomatic dimensions as pain, discomfort, and anxiety and depression. In addition to these results, we developed an approach to combine patient preferences and national value sets based on general population preferences. This project results can be used as information for guidance and for information on methodological approaches for conducting valuation studies for health-related quality of life instruments. And now the most important results from the differences between the preferences of adults and adolescents, the second part of our studies. Health state valuation showed significant differences between adults and adolescents in all 3 countries, to varying degrees, but in all 3 countries. The overall relative importance of health dimensions was to a large degree similar between adolescents and adults, something we hadn't expected. But in Slovenia and Spain, adolescents usually gave more importance to mobility and self-care and less to anxiety and depression. Also quite interesting. The decrements given to the severity levels of the dimension differed slightly between adults and adolescents in all 3 countries. As already mentioned, we found a lack of EQ5D value sets. Therefore, one of the most important results of this working package is the development of such value sets for Slovenia, Spain, and Germany. You see them here. In this way, an index based on the descriptive system can now be calculated. These results will also give guidance on further methodological discussions and approach to value child-specific health-related quality of life instruments. As an example, I show you the Slovenian EQ5DY value set on this slide, which is already published. You can see it here, and if you are more interested in details, then please go to pharmacoeconomics. From the value set, you can see that the most important health dimension in EQ5DY was pain and discomfort, which got the largest decrement for severity 2 and level 2 and 3, followed by the dimensions anxiety and depression, usual activities, mobility, and finally self-care as the least important health dimensions. And this was a picture we saw also in the other 2 countries. What are now the overall impacts of our project results in terms of HTA processes, uptake, cooperation, and so on? And what is the legacy for future research? Well, first of all, we provide additional evidence, what we already knew, but this is additional one, that the reference group in valuation studies has a considerable impact on the utility decrements and therefore on economic evaluation in which value sets are used. Researchers and decision makers have to be aware of this finding, and as decision might be highly influenced by the value set used. Our results also contribute to the discussion on whose preference should be the basis of value sets for health-related quality of life instruments. For example, IQWiG, in the official HTA agency in Germany, they argue for patient preferences. So it's just from the authorities that sometimes selection is already done. And we develop value sets which enable cost-utility analysis for pediatric healthcare interventions with both groups as a basis. But of course, there is a lot of room for more research. Here are just 3 points. We need methods to combine patient and general population preferences because people are getting 17, 18, 19. So if you have a study in this period of time of life, then you need something for the transition. We need more stakeholder involvement on rather normative questions like whose values count. As I said, in Germany, there might be a different opinion about that from the authorities compared to the UK. And as I said there, we need also methods for the transitioning assessments in adolescents and adults. But this might be explored in a future EU project. So for now, thank you very much for your attention from the whole team.
Thank you very much, Wolfgang. I think your research is very interesting, not least because when you're thinking about the transition from care as a young person, a young adult, to care as an adult, standard adult, as it were, I think there are lots of issues related to the way healthcare is provided. So I think this is a really important component to contribute to those sort of planning about how you transition that care.
Thank you.
So I think we've got commentators from LSE and Ellie. Are you both there? I can see Ellie. Do you want to go first, Ellie, because I can see you?
Yes, of course. Thank you, Wolfgang, for this excellent presentation. Now, let me start off by complimenting the 3 teams that contributed health valuation data to this study, because I think this type of studies are always hard because of the field work involved and need to train interviews and all that work. But also you have been pioneering this on the topic of valuing child health and in valuing health state of patients with patients, so that made it even more challenging. And then at the end of your study, you also had to face with the pandemic and how that impacted on your fieldwork. So I think it's a big compliment that you finished this and that you finished it with such excellent quality. There's 2 sides to this project. So on the one hand, you have these patient preferences, and I think it's really intriguing that we now have much more information on potential discrepancies between how the general public sees health state and how patients see their own health state. In the end, it's the health problem is affecting the patient, and most doctors are very concerned about what the patients want for their health. And obviously there's a place for social value sets, especially when it comes down to informing macro level decisions about the healthcare benefit package. But those have always been at the forefront, while there's many more medical decisions also, like the individual medical decisions about what is for you the best treatment options available. So I think it's great that we have this information. And as a next step, probably it's worthwhile considering how or whether there's any systematic differences between how patients see health and how general population sees it, because it seems like undoable to establish value sets for every unique patient group. And besides, of course, individuals may be healthy now, but they may become a patient later. So I was wondering first how you see this. If you have time, you may get back to that. Second part of your work was, of course, the development of these 3 national EQ5DY value sets. So these are among the first value sets available as preference-based measures of child health. And I think this is a really important development, as many jurisdictions are waiting for these value sets to become available. However, here I have a concern, and that is about the unthinking use of these value sets. The instruments are different, and I think in valuation, people treat health states of children potentially very different from how they would consider the same health problems in adult, especially if you measure this on a QALY scale, which is anchored at death, and death for a child is not so great. So these values may be very hard to compare to adult values, and therefore I think these value sets need to be presented with some recommendations to users. And this is my second question. Did you consider this, and what recommendations would you have for users? Thank you, Jean. That was it for me.
Okay, thank you. Wolfgang, while you're thinking, Panos, I think you're going to be our second commentator on this. So if you'd like to make your comments, and then Wolfgang, you can give us quick answers to any questions. Thanks.
Great. So shall I go ahead, Jean, or?
Yep, please.
Okay. Thank you. So I'm standing in for Alesh, who unfortunately had to join another meeting. Apologies for that. But I would also like to echo Ellie's comments in general about the results achieved by Work Package 5. There's a history with that. As you may recall, Jean, we started with a previous initiative, Advanced HTA, and before that, we talked about value sets for patients and the EQ5D, 5L4 for patients. I think the results are great. They demonstrate obviously that there are differences between the general population and the patient population. I very much take Wolfgang's point of view that we do need methods to combine patient and general population preferences, and that's something that we probably need to consider as part of a future project. But in the meantime, enriching the evidence that we have in terms of creating value sets for patients and understanding patient preferences is quite important. And I think it was highlighted by the choices that organizations, you mentioned Ellie and Wolfgang, the UK versus Germany in EQUIC, for example, versus NICE, and so on and so forth. I think these are important considerations to have. Whose values count is also critical as we are making decisions about resource allocation. As we seem to be moving, as we are moving towards value-based health and value-based healthcare, the issue of patient-reported outcome measures will play a much more visible role in the economic evaluation of new treatments. Therefore, the results as far as patient-reported outcomes are concerned are, in my mind, not only extremely interesting but extremely important, because they also capture the patient perspective. And as we have shown in previous research, these perspectives are quite important. They're not necessarily captured by traditional tools that we're actually using. The results of WP5, Valentina and Wolfgang and others as well, are important for decision makers because they reveal the importance of different reference populations, that one size does not necessarily fit all. We know, we've seen that health preferences differ among adolescents and adults, among the general healthy population and the patient population. Adolescents are capable to express their values related to health with a high degree of consistency, but we've also seen, and that's something quite interesting to bear in mind, that national backgrounds or country context seems to be important as well. So it will be interesting to kind of highlight a little bit more what that means in practice. Overall, from my perspective, there is a high degree of innovation and innovativeness in this work package, effectively because you have managed to create new value sets for adolescents. So I think these are reference points for future research, and you have enhanced the small body of evidence that exists already on patient preferences and the importance of considering explicitly the patient perspective in quality of life measurement. That's
Thank you. Thank you, Panos. I should comment here that about 15 years ago, Panos actually listened to me as a patient advocate when I was really belligerent about the fact that EQ5D did not reflect what mattered to patients. So I'm really pleased to see that this whole work stream has developed out of that kind of first step by Panos. So it's personally very exciting for me. Wolfgang, I don't know if you want to respond quickly to Ellie's question, but we also had a question posed by Salah, which was asking, why did you compare adults and adolescents in your last slide? Because they're a priori different. So I don't know whether you can, one brief comment on that as well, please.
Okay, I try to. I think we have 5 minutes left, so there should be some room. So thanks a lot for all these great comments, especially to Panos, who stepped in, and also to Ellie. Maybe I start with one thing, that I think the introduction of quality of life in health economics is something which brought already patient perspective into our work. Of course, it's not just that we calculated mortality, it's QALYs, and there is also the Q in that. So quality of life is something which was highly appreciated. What's new now is that also the valuation of what is said by the patient about his or her health state is now with patient values, so or values from patients. And that's something which is, I think, not very critical for clinical use. When I talked to physicians, they also called for that when they knew how we really calculate that. So that's fine. I think we have some differences in looking on that if we start to do health economic evaluation. Because from a health economic standpoint, you can always say general population might be a better idea if we talk about allocation on macro level. So that was the beginning of everything. And then some jurisdictions, it's not just Germany, it's also, I think, part of US and so on, they were calling for patient values also for the valuation part of the work. And now, when we knew that there are differences, I think the whole work is really starting, because there was some hope that maybe the Y versions, means the child-friendly versions of our questionnaire, of the EQ5D, would be just a translation to childish language. But this was not the case. It was a new questionnaire, more or less, although it seems as if it's the same. So it's not so surprising, after all, that there are different value sets now. There are different perspectives on that, also from the adult population, when you ask them, which we usually do. And now we see also, if you ask adolescents and if you ask the patients, then you see different views on that, on different values which are given there. And Ellie asks the most important question, I think, in all that: what will we do with that? How can we compare? How, especially in this transitions from the adolescent to adult, there is a step which has to be explained, and where you have to be careful with that. We do that usually, but we say, well, you can use it from 15 on 50 years of age, but this does not really solve the problem. And you can use it also till 18, the use version. So there is some overlap. But sometimes we have studies where all this does not help. And after all, if you then, for example, in a league table, compare these results, then you have the same problem when you really compare between the interventions. So I think I do not have the final answer on that. That will be, as I said, one next step on the research agenda. Maybe to the points you raised, Eddie said something about the patients. Yes,
I think we need to move on, Wolfgang. Because,
I'm so sorry, I was too long. I thought I had 3 other minutes, but that's fine.
Well,
again.
but you started earlier, so you've expanded.
You're right.
Okay, so I'm going to move on now. Thank you both, you and Ellie. Very clearly a very interesting topic. I'm going to move on now to, oh, I can see you, Max. There you are, Max.
Thanks. Just sharing my screen. Okay, so in this next work package, we're turning our attention towards estimating treatment effects as an input for economic evaluation, and in particular, doing so through non-randomized studies. This work package was led by me at the LSE and then Seamus Kent at NICE. So why do we care about using non-randomized studies for estimating treatment effects? Well, we know that the gold standard for generating evidence about whether a new health technology works or doesn't work are randomized control trials. And that is because of their high internal validity. So when we think about regulatory, but also reimbursement, coverage decisions, we want to be sure that any beneficial effect that is observed in a study is really due to the treatment that is given to participants. But there's now increased use in the use of non-randomized studies for making these decisions. So in this graph below, I'm showing number of new drug approvals in the US based solely on non-randomized studies. And you can see a clear trend that the number is increasing over the past 25 years. So faced with this increase in non-randomized study, there's a need for empirically grounded recommendations for health technology assessment bodies, but also other organizations who are seeing increasingly this type of evidence being submitted for making decisions. So this is what we set out to do. What did we do? We structured our work into work streams. First, we wanted to empirically assess how treatment effects estimated obtained from non-randomized studies compared to those that are obtained from randomized ones. So here we ask whether randomized and non-randomized studies agree about both the existence of a therapeutic effect, but also about its magnitude. And we focused on pharmacological interventions here on drugs. So we approached this question through a meta-epidemiological study. So this is a study of studies where we are interested in the impact of a specific study characteristic. In our case, that's the random allocation of study participants to treatment and control arms, and the effect of that on the effect estimate that study is producing. So if we have a set of studies with and without that characteristic of interest, that allows us to measure how often the two study types agree about therapeutic benefit and also the effect size. What we did was the largest analysis of this type to date. We identified 346 clinical questions where there were matched randomized and non-randomized studies with a total of more than 2,700 unique contributing studies. And the second work stream was to then translate those findings, but also other previous findings from methodological research into recommendations for HTA bodies. So we conducted pragmatic reviews. We looked at previous existing best practice recommendations, but we also conducted a workshop with regulators and HTA bodies from 8 European countries, resulting in a set of 13 recommendations, which I will briefly talk about as well. What did we find in our study? Firstly, we found that non-randomized and randomized studies led to different conclusions about whether a drug has therapeutic benefit for close to 4 in 10 of all these 346 clinical questions that we analyzed. So in other words, if we only had evidence from either RCTs or non-randomized studies, the conclusion about whether a drug has a therapeutic benefit, no benefit, or unclear benefit would be different about 40% of the time. Secondly, we found that non-randomized studies can both severely over and underestimate the effect that we see obtained by randomized studies as the gold standard. So in this graph, I show the effect estimates obtained from non-randomized studies along the horizontal axis and from RCTs along the vertical axis. And each of these gray dots represents one of the 346 clinical topics. If RCTs and non-randomized studies were perfectly aligned, they would line up along this solid red line through the middle. But that's clearly not the case. And in fact, for 38% of these clinical questions, the dots lie outside this dashed red line, indicating a more than twofold difference in the magnitude of treatment effect. So a very large difference in the magnitude of treatment effect. And finally, when we pool these discrepancies across all the clinical topics, we observed that there was on average no statistically significant difference in effect estimates. So as we saw before, there was substantial variation where non-randomized studies both over and underestimate the effects obtained from RCTs. And importantly, there is a lot of uncertainty about the extent of this discrepancy. So for any given topic, we're not quite sure where this estimate of discrepancy between the estimates obtained from RCTs and non-randomized studies would fall. What we also observed was that for experimental types of non-randomized studies, there was a statistically significant difference in estimates obtained from RCTs, and non-randomized studies overestimating the effects of RCTs by 22%. Where does that leave us? Taking these findings, but also other evidence and the consultation with HTA bodies into consideration, we arrived at this set of 13 recommendations. They're structured around in 6 domains. The first domain is the planning and design of studies, where we recommend that there needs to be a strong justification for doing a non-randomized study. So RCTs remain the mainstay of evidence generation, and also a demonstration that the question at hand is amenable to being answered by a non-randomized study. So this would require studies to be planned prospectively and also in dialogue with the decision makers to ensure that evidence generated is fit for purpose. The second domain is analysis, where we highlight the need to understand the potential biases or risks of bias in non-randomized studies and using appropriate analytical tools to address them, but also to look through sensitivity analysis about what the impact is of using these or different types of tools. The third domain is reporting, and this is all about being transparent by first registering study protocols upfront, reporting the methods, data, and results fully, being open about potential biases, and importantly, also conveying the uncertainty around estimates so that decision makers get a full grasp on the information that is available. And then aimed directly at HTA bodies, we see a need for strengthening systems to improve the quality of non-randomized studies and also the ability of HTA bodies to deal with them. So this includes strengthening scientific advice procedures, but also improving conditional reimbursement schemes where evidence is generated in a post-marketing setting and what that evidence looks like. But importantly, also to strengthen and develop the skills of staff within HTA bodies so that they are better equipped when they deal with submissions based on non-randomized studies. And then finally, looking forward, HTA bodies will need to issue best practice guidance, but also enforce it, and support future research and initiatives like the project that we were part of, in order to better understand and still advance our understanding of the use of non-randomized studies for health economic decision-making, and improve really the quality of non-randomized studies so that we can uphold rigorous evidence standards in the future. Thanks.
Thank you very much. And can I now call on Juan Carlos to commentate on this?
Yes, Jean, I'm here.
Always a relief to see the face.
I was hiding so far. I thank you, Max, for such excellent work. It was also, I have to confess, a small conflict of interest on this commentary because I was part of the team. So I'm going to be really kind to the research team that worked on this project. But I really honestly think they did an excellent work, especially Max, but also Seamus. It was, I think it shows an excellent example of synergy between an HTA organization and the great research team, and I think that really helps focus the research to really pragmatic results and to capture really what is really important for policymakers and for bodies like NICE and others that do similar work to them across Europe. But I think this work package is also an example of how IMPACT HTA has focused their research. I think it responds to a need that is on the table of HTA organizations today. And Max has shown the numbers. The need is a growing need. So it's not one of these topics that is kind of looking into the future and trying to show us what's coming, but it's a topic that is highly topical today, and that needs work like this to understand better how to approach it. So it is, as Max has shown, and as it shows that NICE is part of this work package, a challenge to, for example, NICE, one of the biggest HTA organizations in the world. I am in Andalusia in a much smaller HTA organization, and from my times working at NICE, I remember NICE has several technical support units, if I'm not wrong. I remember a decision support unit. They've got huge amounts of research resources that they dedicate to their assessments, and huge amount of academic support. Smaller organizations like mine don't have that luxury, so it's mostly analysts, and with smaller support from partnering academic units that have to face the assessment of medicines and medical devices. I think that highlights the relevance of this work, because it really helps agencies like mine or other agencies across Europe. I remember our Polish colleagues that were also part of this work package highlighting the need for this work package to kind of digest as much as possible how to approach the appraisal of non-randomized evidence for them. And yeah, I think for smaller agencies, it's even more important than for agencies like NICE or HAS or EQUIC. there is also a policy environment and the research environment across Europe that shows the need for research like this and how topical it is right now. We've seen the EMA doing some research and publishing about how to go about the assessment of non-randomized evidence in their work. They've done policies that actually have shown also an increase in non-randomized evidence, like adaptive pathways, for instance. But also UNETA have been doing some work on developing recommendations to set up patient registries and to help HTA organizations interpret the evidence that is generated in those. And it is to be expected that evidence will be to a great extent non-randomized. We've seen in the research environment as well in IMI a great deal of work done on big data type of projects. Real world data is also highly topical, and even though I was talking about some HTA agencies being smaller and having to some extent often less academic support than NICE, that often doesn't go hand in hand with the amount of data that we handle. For example, in Andalusia, the HTA regional unit is part of a research-focused organization, and we've created a new big data unit that is exclusively dedicated to setting up the policy environment to being able to use big data, real-world data in healthcare policy and also in research. We've got almost 50 hospitals and more than 1,000 primary care centers, a population that is similar to the population of Switzerland with around 4.5 million patients, and the cohorts of patients that have gone through the healthcare system in Andalusia that have generated data of around 13 million patients. So that also shows you that that sometimes regions with smaller HTA agencies have the potential to generate huge amounts of real world data, of big data, and we've got to be prepared to be able to use it and make sense of it. And research like this, I think, is greatly helpful to face those challenges. I believe there has.
If I could ask you to 1 minute left, so if I could ask you to
all right.
to a conclusion.
I'll summarize. I think this research is also really helpful to challenge default positions, and by that I mean by default understanding that non-randomized evidence will be less useful for policymaking. I think the key is what Max has explained, being able to understand how to approach the appraisal of such evidence and put it in context with other types of evidence generation methods that have been used and make sense of them. And I think there are other topics that have been touched upon that could be useful for future research. I think this work has focused mainly on drugs, but I think there is huge amounts of non-randomized evidence also for medical devices, and seeing a meta-epidemiological analysis like the one that Max has done for devices could be really interesting to understand whether there are differences in this field between drugs and devices. And also Max has touched upon about strengthening of healthcare systems and HTA systems. And I think perhaps being able to use the outputs of this research to build some form of kind of easily accessible training modules that HTA organizations across Europe could access could also be a way of strengthening those systems. And I'll close here. Thank you very much.
Thank you very much. I think each work package is giving Panos a great long list of further research topics. And I think, you know, this issue about kind of patient registries, real world data, etc., is something that looking forward, we really need to pay more attention to. I think it is a critical topic. So thank you both very much. Okay. We now have an interesting challenge because we've got 3 people presenting for this work package, and I'm going to ask Panos to start.
Thank you. Thank you, Jean. Let me see if I can share.
I'll keep talking while you do, Panos.
Yeah. Actually, Hala, can you share this screen for me, this presentation? Is that okay? So I hope it's okay. I think you're on mute, but it doesn't matter. So if you can, if you hear this message.
I'm about to share.
Lovely. Okay. So I will share. It's a challenge indeed, Jean, but as you said, challenges need to be addressed face on. So I will share this presentation with two colleagues, Mónica Oliveira from Instituto Superior Técnico in Lisbon, and Aris Angelis, formerly colleague of mine here at LSE and now with the faculty at the London School of Hygiene and Tropical Medicine. Work Package 7 has really been a joint effort between IST in Lisbon, as I mentioned, and LSE, but also TLV in Sweden and several other partners, both associated with the consortium, but also drawn from outside the consortium, because it has involved a lot of work and activity and panels, workshops with different organizations. The starting point, and thanks Hala for changing slides. The starting point for WP7 was that the value of a healthcare technology spans across a multidimensional domain, going beyond clinical benefits and costs traditionally captured in economic evaluation approaches. So HTA decisions could be informed, therefore, following a value assessment and appraisal process that includes all relevant value domains and stakeholders. So turning into the agenda for this work package, first of all, it develops an actionable model of the factors associated with HTA recommendations, which is tested empirically, providing decision makers with insights on the relative importance of different criteria beyond costs and effects at therapeutic class, but also at country level. So this is the first task out of the four. Secondly, it uses participatory processes such as Delphi panels, decision conferences and workshops to propose a value framework. We call it the IMPACT HTA value framework that actually captures the value concerns of different stakeholders that are involved in the decision-making process. And that's task 2. Third, it applies and tests this value framework to demonstrate the adaptability for different decision contexts, focusing on a number of therapies across settings. And Aris will talk to us about that in task 3. And finally, it contributes to the decision and the discussion on resource allocation by adopting multi-criteria decision analysis approaches for the value assessment of medicines to inform decision-making by HTA agencies and health insurers. And that's task 4. Hala, if we can have the next one, thank you. In task 1, therefore, a model of factors that are associated with HTA coverage recommendations is proposed, capturing what we feel are the salient features of individual medicines, country characteristics, product characteristics, regulatory variables, therapy-related clinical and economic performance, evidence uncertainties, and social value judgments. And this model is subsequently tested empirically using historical evidence from 8 country settings based on a panel of 219 unique medicine indication pairs. You can see the countries we drew data from and the total number of observations on the table on this slide here. Now, our empirical analysis, which has actually fed into task 2, has found positive and statistically...
You've had 4 minutes.
Yep, associations between funding decisions and clinical performance, economic variables and social value judgments, and negative associations between funding decisions and clinical and economic uncertainties. Whereas the overwhelming majority of the drugs, about 88%, have been recommended for funding, empirical evidence suggests that most positive coverage recommendations are associated with significant clinical restrictions and funding arrangements in order to mitigate uncertainty and optimize on cost. I would now like to call upon Mónica to present us to the framework. Mónica, the floor is yours.
Thank you, Panos and Jean. So at task 2, our key challenge was to build a multi-criteria framework to help agencies in evaluating medicines on a common value frame, but respecting the specificities of measuring value in distinct therapeutic contexts. So our proposal, the IMPACT HTA framework, works in a way in which the agency involves its stakeholders to reach a comprehensive set of value aspects, and also involves stakeholders in defining the relevance of these aspects for distinct therapeutic indications. Also, the agency defines procedures for committees working within a structured format and departing from that value frame with procedures including very user-friendly evaluation processes that go from qualitative value judgments to numerical value functions and weights with Macbeth approach. So for implementation, the framework entails a set of participatory processes and tools. We have tested the framework with a large number of HTA agency stakeholders in a sequence of Web Delphi processes. It emerged that different stakeholder groups may have different perspectives, but there are a large number of value aspects that are agreed as essential or influential across different therapeutic indications and for most stakeholder groups. We also found out that value aspects relevant for that there are value aspects that are relevant for very specific therapeutic indications. So other details of the framework with application to INAMI and TLV case studies will be described by Aries, to which I pass the word. Thank you.
Okay, thank you. Thank you both, Panos and Monica. So as part of task 3, we completed the development of the framework, and also we tested in practice in collaboration with our HTA agency partners, TLV in Sweden and INAMI in Belgium. So initially we had the validation of the generic value aspects that were generated as part of the previous task. And we also worked with our agency partners in order to select a specific set of disease context, disease areas that would be explored later on as part of the remaining of the task. We conducted another Web Delphi process, that time at HTA agency level with TLV and INAMI. We started by collecting information on potential missing value aspects that could have not been included in the previous task. And later after that, we had 2 rounds of classifying the relevance of the different value aspects across 5 specified disease areas. So if you can click on the next, yeah, thank you, Hala. So this is just a screenshot of the results showcasing that the relevance of the same value aspects might be different depending on the specific disease context under investigation. In that particular case here, we have disease area 1 corresponding to cancer and disease area 2 corresponding to neuromuscular conditions. And so one back, please, Hala, 1 step back. Yeah, and so then the results, the Web Delphi results were validated with HTA agency members. We conducted a couple of semi-constructed interviews in order to make sure that the results made sense. And then finally, we applied the full impact value HTA, the impact HTA value framework in practice. So we followed as we call it, the Delphi Macbeth collaborative value modeling approach at HTA evaluation committees level in order to evaluate 2 alternative sets of therapies, of alternative options for 2 specific disease indications. One corresponded to non-small cell lung cancer and the other one corresponded to spinal muscular atrophy. So we used the Delphi results as a starting point, and then we conducted a facilitated workshop taking the form of a decision conference with 2 sets of participants, well, 4 sets of participants, 2 for its case study, both repeated with its agency. Yeah, thank you. And so we elicited the preference of the participants in order to assess the performance of the different options and produce value scores, but also we elicit the preference of the participants in order to understand the value trade-offs between the value aspects that were included in the models, taking the form of quantitative weights. So if you can click the next one, Hala, yeah. So we generated explicit overall rankings for the different treatment options of interest. And these overall treatment rankings included both performance scores, but also were weighted according to the relative importance to the overall decision. And ultimately, we generated insights and recommendations for policymakers by drawing from the discussion of the results and participants' feedback.
Well, I guess the contribution is both methodological and empirical. Methodological in terms of a model development capturing factors associated with HTA coverage recommendations, but also in terms of producing the IMPACT HTA value framework, which was developed and tested as it was shown earlier on. We also made contributions to the MCDA in literature. And in terms of future research, we probably need to test the framework even more in further context, and also the plan is to build tools to enable a more expeditious implementation of the framework going forward. So the next slide is just an acknowledgement of the intense work by the team, both in Lisbon but also at our end here at LSE. Thank you all very much, and thank you, Jean, for your tolerance by giving us an additional minute and a half.
Yeah, a special concession, Panos. Okay, if I could ask Jaime and Larry to comment, please.
Sure. Panos asked me to go first to comment on task 1. And I have the advantage of having been provided an early copy of some of the papers and appendices, so I have a lot more details than they were able to show during the presentation. But I was struck by several things. One is the substantial variability across agencies and areas. And I wonder what justifies this. Are we really that different from one country to another, especially in Europe? Or does this highlight deficiencies in our field? Are we just not quite professional enough yet? Something for discussion. Second, the uncertainties regarding the effects of interventions are very disconcerting. These are interventions that have been approved. So regulatory agencies have considered that there is enough certainty to approve them. And then here we are in HTA saying, actually, they are so uncertain that we can only approve them under limited conditions or not approve them at all. And it was notable that most of these uncertainties were not overcome during the process of HTA. Something's wrong there, and we need to resolve that. Third, the very strong effect of social value judgments, especially severity, was heartening because we've known for some time that these things really matter to at least to the public. And I'm glad that decision makers are taking them into account somehow. I'm very glad that this work provides some quantitative basis for doing so. And then the last comment is that I'm worried about the distortion caused by the orphan medicine product designation. OMP, as we all know, is not a methodologically relevant designation. It's a weird exception to the methods. And so I wonder if that's distorting a lot of the modeling and the factors. But in any case, I found this very, very useful, fascinating work, and I hope that we have another full workshop to go over all of this information. Thank you to Panos and team.
Thank you. Larry.
Yes, happy to be here, and thanks very much for the introduction. Let me now see if I can manage to share my slides. Where's the button?
If you need help,
here we go. No, I got it.
Okay.
Okay, can you let me just maximize the slides? Are you seeing them?
Yep.
Not yet?
Yes.
Yep.
Yeah, you did. Oh, good. Okay. Well, I also received a couple of weeks ago the documents and read through them, trying to get my head around this. My own experiences with using MCDA to model drugs, and I'm happy to report that now the FDA even has a team who are doing this internally, and a team is being set up and extended in the EMA. So the two big regulators are going in this MCDA route, and let's see now what might be possible for HTA. Well, it was good to see the list of 6 determinants of the funding recommendations go beyond costs and effects, because as so many speakers have said, there is more to approving than just costs and benefits. 23 value framework might be a useful starting point for defining the small world of an MCDA model, but it's excellent that the value framework was positioned as a socio-technical participatory process, because really preferences are not stored in people's heads ready to be plucked out. They are created on the spot when they actually need them. So this poses some extra problems, which I think are solved in decision conferencing. The group in task 2 used the Delphi technique and discovered that there's a fair stability of about what they call 15 to plus or minus 2 aspects out of those 23 that they looked at. But honestly, concerns or aspects aren't value criteria. And tables N 8 through 10 in the report show that a single generic model is very unlikely. I've used it on many things in health technology, drugs, and so forth. And generic models, well, at best, you might find a core criterion across many medical conditions, but with context relevant criteria that are unique to the condition. Well, these two classes of criteria will emerge from long experience of MCDA modeling. So I agree with Panos's view that more trials are needed. Task 3, collaborative value modeling. At last, I see that the concerns and aspects were converted to proper MCDA criteria. However, I find the HTA, as an outsider really to HTA, your language is too imprecise. Decision analysts have got it much more precise. For example, value, we decision analysts believe, is the extent to which an objective is achieved. And the third point is that an objective requires a noun and a verb, right? Morbidity is not a criterion. Reducing morbidity and mortality are objectives. Meeting unmet medical need is an objective, not just the word unmet medical need. And a criterion shows us a measurable extent of the achievement. For example, the treatment halted progress of the disease. That would be a criterion. The treatment extended life by 6 months. That would be a criterion. So I haven't liked just using single words for criteria. That's far too imprecise. So, but the MCA modeling that they did was terrific, and it showed an ability to convert qualitative and quantitative inputs both into preference values. And it also showed how criteria trade-offs establish a common unit of preference value. And it showed the transparency and ease in communicating the model results. Finally, let me just say more about collaborative value modeling. It would be instructive to use the available data with linear and nonlinear value functions to compare fully quantitative models to Macbeth. The inputs to Macbeth are always judgments of difference between 2 points and a maximum of basically 7-point scale. The best part of task 3, by the way, is the policy considerations. You're opening up a larger world than just QALYs. You're concerning yourselves with both clinical and non-clinical value. And you're recognizing that the model structure itself, what criteria you use, depends on the context. There is no one single set. There may be a few common ones. And by the way, for the future, QALYs and contingent valuation models attempt to establish a common unit for comparing across medical conditions. And that's why they've been so popular. However, trade-off weights are the common unit in MCDA, but they're unique to each medical condition. If you want one that's more general, then over time with experience, trade-offs between the medical conditions could also be established with a common unit of preference value emerging. And that's the end of my comments. And thank you very much, Panos, for asking me to do this.
Thank you, Larry.
Thank you very much. That was very interesting. I like this sort of focus on precise language and being clear what it is you're talking about, what objectives are, etc. We've got a couple of minutes before we're due to break, so could I ask Inaki to provide us with your comments that you were going to provide earlier in relation to the costing methodology?
Yes, thank you very much. I'm so sorry for not joining before, but as you know, there are complicated times, especially with COVID-19, and we are not one of the best regions in terms of what we figured out around the figures around the cumulative incidence. Anyway, my comments. So first of all, I think, and this is one of the intriguing questions that we have in different HTA bodies, that is having a cost that could be used in cross-border, and these methods are tremendously useful for us and in many ways. On the other side, one of the challenges, and at least it is, which are the figures that we are used to use, and especially in those that we are working in regional agencies and well, that big countries. Interestingly, one of the things that I feel it is tremendously important, it is where to focus, and I think the work from Joan and colleagues has been tremendously helpful in this regard, and from the health economics that we have in our work and in our agency. One of the things that we use to go with is those systems that are quite alike in terms of how the healthcare system it is organized and structured. In this regard, we always focus in the UK. Probably because of the structure of the system and how it is organized and consistently. I don't think there is a sole methodology that has been published so far, and perhaps other health economists correct me if I'm wrong, that could help us in entangling this issue. So my question to Joan and colleagues would be, if that could be also be useful in terms of those that we are considering, and if it could be also helpful to have some kind of such a database in which we can rely on in terms of doing also the economic evaluations that we are doing so far. So more I would say acknowledgements and congratulations to the work done than any further question. But also it would be good also if those initiatives could be shared at least at the European level, in which perhaps the systems are much more alike, but also at the international level. And a further question would be if the systems that are nowadays in place in terms of defining the DRGs could be, and you think could be also useful in this regard. And that is my question.
Okay, Joan, do you want to respond quickly? Or Susanna? No, I'm not sure that either of them are there. In which case...
Well, they are there. They don't want to answer me.
Okay, we won't go there. Carlos, do you want to make a quick comment before we break?
From the last thing that Iñaki mentioned about DRGs, yeah, I think it's a very valid point, Iñaki, for consideration. Obviously, I haven't been involved in that team's study development, but obviously knowing the methodology, I think you're raising an interesting point there. More to our work package, I'll probably leave it to Monica or Aris to comment further on the MCDA, on the model and the econometrics. I'm grateful to Jaime for the comments he made, and he mentioned a point about the orphan medicinal products at the end. No, I mean, we did some robustness checks, and the inclusion of the OMP variable, so to speak, did not affect, so to speak, the results obtained elsewhere. So I think that is an interesting one. I also took heart from the inclusion and the statistical significance of social value judgments. And I take the point about the disconcerting nature of uncertainties. But as Iñaki pointed in one of his comments, and I took that point on board, it's not HTA, it's decision making, isn't it, Iñaki? So I think you made that point, which I thought was very interesting. As I can go on, Jean, but I think I'm grateful to both Larry, obviously, because of the time that he has taken to respond in detail, and that the point about precision is also very important. There may be some issues for debate between all of us here amongst the team, but also with Larry and Jaime. But we'll probably take that later on offline.
I think so, because I think
very rich discussion, very rich.
Indeed. We're due to close for a 10-minute break. And I did want to say, in response to Jaime's comment about the issue between sort of what a regulator accepts and what an HTA body accepts is a major issue for patient organizations. They cannot understand how a regulatory body says this treatment works and an HTA body says it doesn't work well enough. And that is a real kind of challenge for patient groups. And with that, I'm going to ask you to have a break for 10.
You've just opened another point for discussion, Jean.
No, I was making a comment. Right, we have a 10-minute break. We'll start again in 10 minutes at 15:20. So please all stretch your legs and get some energy.
Thank you. Thank you very much.
But we can talk about that for ages. Believe us.
Yeah. When I first got to the EMA, I said to Thomas Lundgren, why don't you just handle over a model? We could do an MCDA. Why don't you just handle it over to the HTA? He just
because it is not that easy, Larry.
I know. I discovered that after working there for 3 years.
Okay. Yes. Silence from everybody. Okay, assuming we are, our next work package, we're due to hear from Senior and Irene and Matteo, but I'm not sure who's going first. Americo, it looks like
Hi, Jane. No, I Jane. Irene at the moment has a problem with the PC, so we have shared the opportunity to anticipate the presentation of work package 9, so they will have the time to, to restore the situation. I don't know what happened actually, but I'm available if you want.
Yes, please go ahead, Americo.
Okay, great. I'm going to share my screen. Just let me know if you can see my presentation.
I can.
Okay,
yep,
great.
Super.
So, very briefly, to the interest of time, this work package was dedicated to the development and testing of this framework. Actually, this has been published recently, thanks to the collaboration with Matteo Ruggeri and Eugenio Di Brino and the rest of the team. Here, the basic idea is to look at the impact of introduction of new technologies or new health intervention and policies on the productivity of work, so in the perspective of the human capital, but trying to look further and to understand the implications in terms of economic growth. As we know, the accumulation of human capital is one of the drivers of economic growth, of course, and the idea is that governments should invest in new technologies, but also to implement policies that are able to increase population health. So the idea is to enlarge, not to substitute the actual models for economic evaluation. The framework in general, I'm going to really present some snapshots of this long work, is starting from the ability of a policy or the ability of a new health technology to increase the people in good health. When these people is in the period of the life in which they are productive, this is going to increase productivity of patients, but also of caregivers. And among the other impacts, we can have an impact on their income and as a consequence on tax revenues. More tax revenues means availability of more resources for public health expenditures, and this an investment for increasing the health. This is the the logic model, and of course the idea was trying to capture all these interactions that again are fully described in the paper that has been published in 2020 in the International Journal of Technology Assessment in Healthcare. I'm going immediately to, let's say, the final toolkit that we have prepared. On the base of our model, we have developed an algorithm for the for estimation of fiscal impact of new technologies or health policies that are able to increase the productivity of people, trying to look at the implications for, as I said, income, tax revenues, and public health expenditures. This algorithm is a model, is running with Excel, and the choice was based on the idea to give the opportunity to the broader population as possible the availability of this tool that is designed to be very, very easy to be applicable in different constituencies in which regulation for taxation, regulation for social security are different, and it was actually a real challenge trying to identify those variables that are the most important ones to be considered to have a model that can be generalizable. What we have produced is a real user-friendly checklist, able to conduct quick surveys, or also you can use this checklist to find secondary data or for using data coming from the literature. And this checklist is putting in evidence the major variables that are needed to run this kind of model. So age, sex, the region in terms of territorial area, the educational qualification that is relevant for the further description of the work activity, so the condition of the employment, self-employment, freelance, because we think that all these variables are having an impact on the income as well as the average weekly working hours. Of course, all in this checklist, there are elements to determine the impact of the health policy, such as, for example, the reduction of complication related to the use of the technology or the implementation of the policy. We have applied this methodology on 2 different case studies. The first one is on a population with type 2 diabetes. And the second case study is related to a population with ostomy and intermittent catheterization. In the first case, we are assuming that the implementation of an home telehealth program can reduce the ability to increase adherence. Yes?
Americo, you've had 7 minutes. So.
Okay, great. The adherence, and so these have an impact on hospitalization. On the other side, in case of ostomy, the implication is the annual increase, 5% of the home distribution, which affect the indirect cost of target population. We have data that we have been showing for the 2 case studies. I'm not going, of course, to describe the results, even if here you can see the count of the fiscal impact in the different ages of these population. We have also applied a bootstrap analysis to understand the variability, and similar is the the results that are coming from the model applied to the ostomy. Actually, just really few comments, because of course in 10 minutes was impossible to show all the characteristics of the model. But what we think that this kind of approach can be useful in actually in the case in which an health technology and healthcare intervention is creating a significant impact on specific populations from 18 to 65, so active population. Of course, this is not creating any fast track for those technologies that are applied to productive population, not for elderly or young people, but is creating an extra evidence regarding the economic impact. And this is online with the idea that an health intervention actually is an investment. It's an investment from the perspective of the health of the population, but also is an investment in terms of economic value that can generate. Of course, we need to implement. Yeah, we need to, as a further research, to implement this model in other clinical areas.
Super.
Thank you.
Thank you very much, Americo. I'm sorry for having to chase you. And now we have, I believe, comments from Inaki and Andrea.
Who do you want to be first? I don't know.
You, I can see you, so we'll go with you.
Okay, so first of all, thank you very much, Americo and the team for this excellent piece of work. This is something that we have been, those that we have worked for the government, and we continue working for governments. This is always a tricky question: which is first, economy or health? And I think it is you have put the focus on something that is intriguing and important. Nowadays we have also the discussion within the lockdown, which is first. Once again, it is economy and productivity, and then health. Obviously, the right path was health, but we need to be reminded that maintaining the economy was transcendental. We performed a similar analysis some time ago of the overall expenditure in the Basque region, and which was the return on that investment in terms of health and productivity, and we discovered that more than half the budget that we devoted to healthcare was returned back. So it is, but it's also interesting to go in terms of pathologies. That is the way that you have done. In this regard, do you think that this type of methodology could be useful in terms of determining the silos of budget that could be devoted from the healthcare systems, and in this regard, perhaps having a more fair approach, obviously from a very utilitarian way of doing, in terms of determining in which to focus the the budget. Obviously, being sensitive in some certain areas in which we can say, well, perhaps the utility is not that high, but we need to continue being sensitive. But I think it is tremendously interesting in going that way. And I don't know if you are thinking about exploring this, because that could be also a way of determining the silos that I was mentioning in terms of, well, I'm going to devote that portion of the budget in terms of oncological processes, and also determining, depending on the indication, and similarly in cardiovascular diseases and other type of areas of pathologies. Have you think about that?
Thank you very much, Iñaki, for this comment. Actually, yes, even if we have not implemented yet, let's say, a model to understand which are the implications from this point of view. But I agree with you. I think that this kind of approach can help in the definition of dimensions of the different silos, because at the end of the day, we know that in many countries, for example, in Italy, we are using silos to manage healthcare expenditures, and sometimes these silos and the dimension of these silos are based only on, I mean, very, very, let's say, administrative considerations, without any or with few, let's say, evidence on which the amount of money to be produced in the silos is rooted. But on the other side, I think that this is an approach that can be used also to really to have the financial plan of not only the public health expenditure, but the public expenditures. Because I think that generating this kind of evidence, we can have more arguments from the perspective of Ministry of Health to support investment in a specific policy or in a specific health technology. Again, there are the limitations, some limitations, and some point of attention. We need really to think about the the ethical implications of such an approach. Is something that should be really handled with care. We are, aware about this. But nevertheless, I have to say that we are really at the first
up to now, those positions are not taken into account. So it is
absolutely.
So we have decisions around budget, and not even those methodologies are applied. So anyway.
I don't think now's the time to have a debate about quite how this operates. Americo, did you have anything further you wanted to respond? I can't actually see your second commentator, Andrea, on the list of participants.
Yes, Andrea is there.
Good afternoon.
Can I just ask you to make your comments fairly quickly then, please?
Yeah, absolutely. I think that such a presentation could be really important in the perspective, for example, of institution like the Ministry of Health, in order to enter in a really a very constructive way in the logic of bundle payments. I mean, the indirect costs are really important if we are trying to create processes in healthcare, trying also to focus on prevention, and in the perspective of a national health service like our Servizio Sanitario Nazionale, it's really important to have this osmosis between different silos, like the healthcare silos and the labor silos. So in this perspective, I think that it's really, really important also in management of chronic condition. For example, the example on diabetes is really concrete if we are thinking about in this moment in Italy, but I think in every European country, in how to strengthen the primary care sector in this situation. We are now within the pandemic, but we are thinking also thanks to the Next Generation EU funds to how we can reshape pathways and networks, and having the estimate of indirect cost is absolutely essential to have in a strategy, in a value-based strategy, all the instruments that we need to plan and organize healthcare sector. Thank you very much.
Thank you very much. Okay, I think we probably need to close this conversation down now. Thank you, America, Inati, and Andrea. We're going to go backwards now. I can see Irene, and we'll hand over.
Apart from seeing
and I can hear you. I can
Good.
hear you and I can see you. So we'll hand over to you now, please.
Okay, I will try and share my screen, hoping this works. Actually, it's Professor Cicchetti screen to be precise. So can you see the presentation?
Yep.
Okay, perfect. So this work package is about the analysis of economic evaluation methods for hospital-based assessment. And what we have dealt with in this work package was to try to understand how hospital contextual factors may affect hospital performance. In particular, how performance may be affected through the effect that contextual factors may play on how good hospitals are at using health technologies and how contextual factors may affect clinical variability. The issue rose due to the fact that the same health technologies may indeed produce very different effects in different settings. So although health technology assessment provides guidance in adopting, using, and dismissing technologies, we tried to understand which contextual hospital factors may indeed make a difference in how well technologies are able to produce their intended effects. We used a mixture of methods, of both qualitative and quantitative methods, and by triangulating the results of these various methods, we came up with three outputs, with three practical toolkits. The first toolkit aimed at explaining what we should intend by hospital performance variability, so to able to capture its main indicators and dimensions. The second toolkit aimed at understanding the transferability of evidence produced in other jurisdictions outside hospitals and in other decision-making levels. And the third toolkit aimed to identify the clinical variability and its impact on health technology. So starting from the first toolkit, aimed at understanding which dimensions of hospital performance should be assessed in order to provide an effective understanding of its final performance. We provided a toolkit that is divided into more sections. It's a modular toolkit with a core section in which a list of general hospital indicators are assessed, and then specific sections built on top of the typical indicators in clinical departments. Basically, the toolkit, which is on an Excel sheet, is divided in this way. And basically, each hospital can assess whether its target values, both at the core section and each specific clinical directorate section, have been reached or not. And moreover, apart from being a mere list of indicators, these indicators have also been divided into dimensions such as efficiency, effectiveness, patient-centeredness, and so on. The final result of this toolkit is a very easy to use tool, which allows to have a very direct visual statement of how well a hospital is doing in both core dimensions, so in a general hospital dimension, as well as in its various clinical directorates, but also divided into the various dimensions of performance. And this allows both, let's say, benchmarking activities with other hospitals, as well as monitoring performance in time. The second toolkit we have produced was aimed at trying to understand how hospital contextual factors are able to affect the extent to which health technologies are used effectively. And this is a second online toolkit divided in these following sections, in which basically what we provide is, well, first the description of the technology that we are assessing, and then a list of items, each of which is described, and each of which must be assessed as either an enabler, a partial enabler, neutral, partial barrier, or barrier. Basically, for various dimensions that our studies have suggested are able to affect a hospital's capacity of using a health technology, we provide a list of items, and hospital management is invited to assess for each of these items how it is to be intended within the specific hospital. The final result of this online toolkit is also an easy-to-use dashboard, which allows to have an analytical view of the items that are either enabling or hindering an effective use of a technology, but also, let's say, an aggregated vision in terms of dimensions of contextual factors, which are, for example, leadership styles, human resource management tools, and so on. And so this is also a toolkit that allows a very evident way of assessing how adequate the hospital context is in adopting at the maximum of its potentiality a health technology, as well as comparing this context with possible other hospitals if used in an extended way across hospitals. And I think my colleague Matteo Ruggeri will present the first toolkit.
Yes, thank you, Irene. Can you? Yes, thank you. Okay, the third toolkit.
I make sure that you keep moving, because otherwise we're going to run out of time to hear everything.
Yeah, okay. So this last toolkit aims to assess the clinical variation due to different use of health technologies, which may have the same effectiveness, and aims to assess the impact on the efficiency of healthcare deliveries. Our rationale starts from observing that, for example, in Italy, due to some series of jurisdictional differences and different regulations and grades of implementation of actual regulations, the acquisition costs of medical technologies can be very different within the same region and also at a local level. So we implemented this model in order to assess what could be the potential impact of pursuing efficiency by setting the use of resources at the same level. So we use the efficiency frontiers methods. We took into account the minimum cost incurred by different health structures in offering some medical devices. We took the example of the hip replacement prosthesis. We also implemented the model so that it allows for the design of strategies that are aimed at pursuing an improvement in either economic and technical efficiency through the application of some decrease coefficients that we expressed as percentage on each cost item that we considered and that is representative of the resources used. Our dataset was taken from the registry for the use of processes in the region Marche. We took into consideration three healthcare deliveries in the region Marche. The model allows to place healthcare facilities included with respect to an estimated efficiency frontier and with respect to the value of the DRG that is reimbursed for the performance of the hip replacement operation, surgical operation. So we have the deterministic part.
Can I ask you to get to the conclusions, because we're running out of time for your session? Thank you.
Yeah, it's finished. These are simply some results. You can see the optimization results. So the toolkit is, you know, user-friendly. So it's just a sketch of what the results could be. And of course, the efficiency coefficient ranges 0, 1. And Irene, can you go? Yes. And this is the stochastic part. So we have in different colors the simulations that you know, estimate the variability of the total costs of the three deliveries that we considered, and the line is the efficiency frontier, which is represented by the DRG value. Okay, thank you, Rene. Okay, and that's all.
Thank you very much. So we have two commentators. I'm assuming that, Senior, you're not presenting anything, so good. So we have two commentators, Rabia and Francesco. Are you both there? Whichever one shows me, go first.
Rabia is here. I
it?
can go first if you like.
Oh, okay. Hi. Yes, please.
Hello. Thanks for the invitation and great presentations, although it's so quick and I'm afraid of the tough moderator, I have to say. But what was interesting for me in these two presentations is the emphasis on contextual factors. As we all know, in HTA, we talk about it a lot, that the context matters and it's so different from one setting to another. But when it comes to hospitals, it's even more difficult, as even in the same country, in the same city, the context is different from one hospital to another one. And I would go maybe a few sentences about transferability and the fiscal impact, because the issue about the transferability is the decision-making processes are different from one setting to another, for sure, for the hospitals. And the management of the finances is totally different. So I would like to ask the team, actually, did they really manage? Because we haven't seen, like the external people like us, we haven't been able to use the tool yet. So when you piloted, did you see, can you really address these things on the transferability issues, or have there been any major challenges you faced when you were working on this?
I don't know who's going to answer. Irene, Matteo, Senior?
Can I answer?
Yes.
For what concerns the toolkit about the estimation of you know, the efficiency frontiers, that's why we used a probabilistic approach. So that in our opinion, the probabilistic approach more or less allows to map the uncertainty related to different organizational parameters. Of course, I think that there are some structural variations, such as, for example, heterogeneity and so on, that should be included in the model. So it could be a further development.
Yeah, maybe I would just like to add on our side that indeed taking into account the contextual factors is aimed exactly at doing this, trying to put emphasis on which dimensions should be controlled for in order to assure an effective transferability.
Okay, thank you from my side.
Okay, thank you. Do we have Andrea on the system?
No, actually, Francesco Menini should be here, but I cannot see him. Probably he had some issues, technological or organizational issues. So I think that.
So we think that's it, America. No. Okay, well, thank you all very much, in which case we will move on to the next work package. And I think, Elena, that's you going to lead it.
1 second. Sorry, 1 second. Okay. Great. Thank you, Jean. Thank you, everyone, for your presentations. So I have the pleasure to give you a very quick overview of the work that we've done in Work Package 10 and the appraisal framework that we developed, which is suitable for rare disease treatments. Before I begin, I just want to acknowledge the co-PI of this work, Karen Facey, who was central in driving this work, and the whole team who's been brilliant and very efficient. So the background to this work stemmed from previous research that recognized that conventional HTA may not always be suitable for rare disease treatments. So we put together this work package where we're looking at 4 different work streams, which all feed into the final appraisal framework, which I'll be presenting later. In the first work stream, we explored whether countries are treating rare disease treatments differently and developed 36 individual country vignettes of the appraisal processes for rare disease treatments. And on that base, we characterized what different processes for rare disease treatments could look like on the right-hand side here throughout the process. We then worked closely with different HTA bodies. So we worked with SMC, NICE, and CADET, who kindly accepted that we can observe the appraisal committees of a number of drugs that are listed here on the right side. And we also conducted a number of interviews with the people involved in these appraisals. And a lot of the findings and ideas of what worked well in these different settings were sort of taken within our appraisal framework. And the third work stream, quality of life impact, is important in rare diseases because of the severity of these conditions. But in practice, we've seen that it's not always easy to challenge, particularly in rare diseases, to capture in rare diseases. So we start by reviewing the literature to understand what is known when we collect quality of life data and rare diseases. And we also conducted an analysis of HTA reports across different countries to understand how quality of life is influencing these decisions. And on this basis, we also derived 5 recommendations separate from the framework, but aligned with the recommendations of the framework on how to better use PRO data and utilities in HTA for rare diseases. And finally, we then delved into outcome-based managed entry agreements, and we developed some tools on how to determine the feasibility of an outcome-based managed entry agreements, as well as templates for data collection and monitoring of these schemes, and a patient group submission that can be used for later reappraisal. In parallel, there are 2 major papers, publications, which are about to come out. The first one is an analysis of all outcome-based managed entry agreements in Italy, which is one of the sort of more advanced countries in managed entry agreements. But we also conducted 2 case studies across different countries, comparing sort of the specifics of the outcome-based schemes in these countries, and a lot of interesting insights have come from this work. So while all this work was being conducted, we continuously refined our thinking about, how can these appraisal processes be improved to better deal with the unique circumstances of rare disease treatments. And we recognize that HTA processes can be adapted with different process adaptations, which can help deal with the high uncertainty characterizing this evidence, but also the high costs. That there can be broader value frameworks which account for considerations beyond clinical and cost effectiveness, such as the nature of these conditions, but also ethical or organizational issues. And finally, a number of decision modifiers, such as severity and unmet need, or the fact that they often impact children, where there could be a greater acceptance of uncertainty and higher ICERs. Question mark is a big question mark across a number of countries is whether or not rare or ultra rare or non-cancer can be considered a modifier. However, we witnessed that that wasn't necessarily enough, and that these processes could be shaped in a way to ensure that committees are able to make the best decisions possible. And so this brought us to developing our appraisal framework, which is suitable for rare disease treatments, but also for other treatments that have similar complexities. And this framework should be applicable to each individual country's existing systems, with or without the process adaptations outlined in the previous slide, but where we thought to highlight a number of recommendations throughout the process that need to be accounted for. And the first pillar is around evidence submission and critical assessment, where the recommendations are around all dimensions of value should be addressed and all the uncertainties should be identified. In the second pillar, and around the structured appraisal deliberation, there should be detailed consideration of each aspect of value. And finally, throughout the whole process, I think key was the iterative clinical and patient involvement that can help explain that context of the disease and the care pathway and the experience with the disease, but also can help reserve uncertainty. So the aim of these recommendations is to ensure that the process is flexible to help deal with the unique circumstances of each rare diseases and the uncertainties that are going to arise in these diseases, but also that it is done consistently across all drugs. So for each of these three pillars, we developed a set of more specific recommendations. Don't know if I'll give them justice, but I'll just run through them, and I recommend reading the full report that has just been published on the website that Karen has finalized, I think last week only. So in terms of evidence submissions and critical assessment, the first recommendation is that the entire process is shaped around clearly defined decision domains and modifiers, and that therefore evidence submission requirements and critical assessment should be focused on these. Second, all relevant evidence is obtained for each domain of decision-making and all modifiers. So industry submissions need to generate the best evidence possible and include evidence on the nature of condition and the other domains that we've highlighted before. Critical assessment of clinical evidence explicitly considers what evidence could have been generated in the rare condition. So it's important to consider the evidence in light of what is feasible in that context and whether the evidence covers what is most important to patients and whether it is aligned with the descriptions that have been received by patients and clinicians on what the impact is to live with a disease or to take the specific treatment that is being assessed. Fourth, critical assessment of economic models takes account of paucity of knowledge in rare diseases and judges whether the model is sufficient for decision-making. In some cases, there may be so much uncertainty that it may not be possible to make a decision based on the economic model. Now, if we move on to the recommendations around structured appraisal deliberations, the fifth one is that appraisal committees are ideally bespoke for rare disease treatments, or general appraisal committees include several rare disease specialists. We've seen that it's important that the committee members, some of the committee members, understand the nuanced challenges that we can encounter with rare diseases. The deliberative appraisal discussion is driven by the domains of decision-making, and use of modifiers is clearly understood. And so each are discussed carefully, and the process for balancing the domains is clear. Seventh, uncertainties are characterized in terms of form, extent, and implications for decision-making. And it's important also to recognize that in rare diseases, there are uncertainties beyond parameter and structural uncertainty, such as unknown disease. So very often the progression of the disease or natural history may be unknown, which may create uncertainties that are not common in other conditions. And finally, outcome-based managed entry agreements may be used to resolve decision-relevant uncertainties if data collection is feasible and sufficient to do so. And across all that, most importantly, is this iterative clinical and patient involvement, which is here to help explain the context of the condition, what it is to live with the disease, what are the existing care pathways, but also clear guidance on what kind of uncertainties can they help resolve. Does their story align with the clinical evidence that's being presented, and if it isn't, account for that and make it articulated specifically. So this is our appraisal framework that we have developed. I just want to show this next slide. We've sort of done a number of publications around this. Like 3/4 of them are published. Many of the others are soon to be published. Please email us if you have any questions. And I come back to this slide and hand over to Jean and Vincian for the discussion.
Thank you, Elena. If we could move on now to Vincian, to your comments. You're mute.
Thank you. I'm unmuted now. So yeah, I'll offer some comments from a developer's perspective. I'm working in gene therapy and in HSCT gene therapy for rare diseases, so it's slightly a different angle. And first, I really impressed by how rich and with a strong depth of understanding from the nuanced rare disease challenges this report and this work has shown. I think it's quite a unique piece of research. So far, we have heard a lot of bits and pieces, but this is bringing it really nicely together. It's very timely, a very important moment as well, when in Europe we discuss, urban HTA or cross-border collaboration, and where rare disease is often brought forward as a topic where collaboration is possible or needed. So I think those recommendations are really timely to inform possibly some of those processes or some of the thinking around that. So the work is very rich, so I certainly cannot do justice to all the comments and the outcome. So I just wanted, from my perspective, to stress one or two things or three in the recommendation as they are here on the slides. The first one is actually the call for the clinician and patient input. And so that might happen in some jurisdiction, it doesn't happen everywhere. But I think that's really invaluable. And I would really, what I thought was really interesting as well is you recommend almost to start the appraisal with a perspective from the clinician and from the patients, almost on a video, so that it could be used later as a reference, but that could give actually context on the challenges with this disease, the practical challenges with treating and living with this disease. And that can already set the scene and maybe solve some of the misunderstanding later down the road. So I would really be also curious to hear how acceptable or well received this type of methodology would be. Well, there are more recommendations, of course, on how to also include patients and physicians and giving them more guidance around what HTA really expect from them. We heard physicians coming to a table from HTA assessment, but they have really very little health economics culture or background. And so if you're very naive to a HTA process, it can be very almost disorienting for a clinician. So there's also a need to bridge that gap and with the patient as well. So that's one. And another point about the patient and physician is this notion of iterative input. So they can also be, during the process, a go-to resources when there are questions or uncertainties. And we'll come back maybe on that when we talk about feasibility, but that's really, I think, a really key component of this recommendation, and how to do this would really be interesting. Then a point I want also to make is on the modifiers. You mentioned the modifiers. I think for developers, modifiers are, it's important that those modifiers are quite clear, because it's probably for us also a signal of, what is socially desirable as innovation. And if you have pediatric or children being one of those modifiers, that means also that, that's something that would be valued or extra value in the assessment. And then again, around pediatric, I think in the report you were pointing, many of the rare diseases are pediatric diseases. Some have genetic pediatric disorders, so it's quite specific. And I'm not sure in the HTA process you face a lot of the pediatric indication. Usually it's an add-on to an adult indication, so it's rarely a standalone. So there were questions around, is this area of pediatric assessment underdeveloped? Should we take more in account the impact of genetic disorders on families, you know, income, on siblings? So is there something, a dimension where maybe a more holistic framework or something specific for children should be considered? So I thought that was also a very interesting point in the report. And then my last comment will be something that's more that's more about the evidence. We know that's often in rare disease, that's a bit the pain point, is how much evidence do we have? And I think that what's really interesting is this report is that they recommend to take into account feasibility. And because that's often also in the limit. So on the one hand, you need companies to do their best effort to develop the best evidence possible. But you also need to, for assessor, appraiser, regulators, HTA to somehow understand the limits in the rare disease field. What is feasible in a certain period of time? What is a reasonable, what is really that best case of evidence? And there's sometimes mistrust between parties, whether you really did your best effort or whether you really understand that this is such a rare population that we couldn't really do more. And I think that's where, again, physicians and patients can help maybe to bridge that gap or that trust, just to make sure we look, or rare disease specialists, just to make sure that there is trust in that the package that is on the table, or that the package on the table is critically assessed versus quality, but in reasonable limits, taking account feasibility, actually. So I think that's a very interesting recommendation. So that's my comments, and I'm really looking forward to see the life of this report and see what people will derive out of this great piece of work.
Thank you, Vincent. The kind of rare disease space is very special to me. It's where I started my working life in the laboratory, working on rare inherited storage disorders. And as I tell everybody, nobody had ever heard of them until Genzyme started producing some very expensive treatments. And suddenly everybody knew about them. And I think that they come with a whole lot of issues. So I think this is a great piece of work. And like you, I look forward to seeing it actually being used in practice. So I think
have I got 1 minute just to respond to Vincent?
1 minute.
Yeah. So just to say, it is absolutely feasible to have clinicians involved at the outset of HTA. It's something we used to do in fuller HTA. And I think it's something we need to reintroduce for rare diseases, because there is this paucity of knowledge, which we need to put alongside the paucity of evidence. I think that a number of things you've raised are answered by the work packages of this IMPACT HTA. So WP4 looks at the impacts on families and carers, and we highlight that as being particularly important for rare diseases. WP2 gives us a really transparent way of looking at economic modeling. And we think that this is at the heart of everything in terms of being able to discuss the construct of the economic model, particularly with clinicians, to make sure that your central point for the determination of value in terms of economic evaluation is as good as it can be. And I'll just pause there. The only other thing I would say is one of the most important findings here is that modifiers is not stated by anybody in terms of children. Nobody states that explicitly, but when we have spoken to all HTA individuals, they all say, yes, we treat childhood diseases differently. So one of our call is, as you say, for transparency around these ways in which we're making decisions, so that we all know how decisions are made and can provide the best possible evidence.
Thank you, Karen. I think we will move on now to our final work package, and I'd welcome Lisa to present.
Thank you very much, Jean. Unfortunately, I cannot. Here we go. Okay, thank you very much. I'm very happy on behalf of my colleagues to present work package 11, and it aims at incorporating behavioral aspects into HTA, in particular eliciting preferences and focusing on policymakers. We focus on implementation issues, and we want to look at implementation issues of HTA guidance. And we actually chose to focus on the well-known Southwest quadrant, for some, the Wild West, indeed, because we are looking at what is called decrementally cost-effective interventions, i.e. interventions which are cost savings, but they may marginally diminish individual health outcomes. And the savings can be reallocated either to patients in the same disease or to other patients, or also to other uses, such as outside the healthcare system, and all this to maximize population health. So work packages 11 addresses these DCEIs, which present an optimal cost outcome combination, just as incrementally cost-effective interventions, but their potential remains undervalued, and they have received much less attention from HTA bodies. And there is indeed a complete lack of evidence about the willingness of decision makers to accept a quality reduction for cost saving. And the question we want to ask is, are they ready to consider DCEIs amongst a range of treatment strategies? Are they willing to adopt DCEIs? And if so, under which conditions? So we produced a systematic literature review that was carried out by Isabelle Durand-Zaleski, who's co-PI of this work project, and she was in charge of task 1, which was to identify the evidence on DCEIs, then document HTA bodies' practices on a subset of these, and finally, all this was to inform the empirical part of work package 11, where we run a discrete choice experiment to elicit decision makers' preferences. And we generated a number of results. The first one is that health loss and reversibility are indeed the most important attributes. Cost savings are found to play a greater than expected role in decision making. The third result is that disease severity and uncertainty about cost savings are important sensitivity attributes. And the need, we found out that the need to calibrate carefully the DC, for example, exclude high severity, and also use a qualitative approach, both at the beginning and the end, to discuss the results. And also, we had a lot of feedback from those who took part in workshops and who sort of showed that the discrete choice experiment was definitely a very good way to address the issues of a possible conflict between individual and collective benefits. We've also produced a political economy report to document the distinctive characteristics and welfare properties of DCEIs, to analyze their ethical underpinnings, and also to compare healthcare policies across different countries. On the efficiency and equity considerations, which is really at the heart of our work, we showed that DCEIs do differ from cost containment per se, and they can sort of improve overall sustainability of healthcare systems by eliminating obsolete or dominated interventions. They do contribute to maximizing population health by reallocating savings on key incrementally cost-effective interventions, and also they may help accommodate special needs by prioritizing costlier alternatives on target populations. So we also sort of found out that including DCIs in the set of comparators does trigger participatory discussions about the underlying principles and social justice value judgments. We produced 4 main recommendations to ensure appropriate adoptions of DCIs. The first is mainstreaming, i.e. when deciding about implementing a new intervention, decision makers shall be encouraged to systematically consider DCIs as ethically licit and politically acceptable alternatives to usual care. Inclusiveness and transparency, decision makers shall be encouraged to actively involve all stakeholders early on in the decision-making process for securing understanding and possible adherence in case of adoption. Exhaustivity, all forms of DCIs should be considered, such as complementary non-pharmaceutical interventions, for example, physical activity, or stepped care approaches, defining first line and second line treatment. And finally, in terms of social justice and ethics, considering DCIs in the HTA process should foster an explicit discussion of these underlying value judgments, ethical and social justice principles that are embedded in the anticipated savings reallocation. We produced a toolkit with 3 different tools. The first tool is actually the discrete choice experiment itself, which, as I said before, has been used by policymakers in their own decision-making area, be it at the pricing committee or in HTA bodies, to bring to the fore the possible conflicts between individual and collective states. And so it is available. A second tool is the ethical political checklist, which has been produced to inform the appropriateness and acceptability of considering DCIs as a part of a treatment choice set. And finally, once we've discussed in the first step and considered in the second step, the third tool is about adoption. And a decision tree has been defined to focus on the 3 main attributes which have been found to be most influential in the discrete choice experiment, i.e. health loss and quality, cost savings, and reversibility, the ability to go back to usual care with a certain time. And this tree is meant to guide a decision maker's choice of adopting DCIs. And walking through the tree implies either deciding that it is not acceptable to adopt the DCI, or possibly consider the DCI by then turning to the 2 attributes, which are cost savings, what is their size, what is their importance, or the reversibility, how long does it take to go back to standard care. Again, on each one of these 2 attributes, it may turn out that it is unacceptable by decision makers, or it may be acceptable, in which case the next step is to look at the sensitivity attributes, which are uncertainty related to the expected cost savings and the severity of the disease. And again, the outcome could be non-adoption or adoption based on additional data collection. Impacts is basically to offer, to show that there are margins of action to scale up interventions and to maximize population health while ensuring core values of European health care systems, and also opening the door for more democratic debate on resource allocation practices, which are often implicit. And future development is basically more collaborative research action with a number of HTA agencies to document the willingness of decision makers. So enhancing the current experiment by documenting the population preferences and the patient's preferences compared to that of decision makers, on which we focused here, and also expand research to mixed clinical approaches such as step care or combined use of pharmaceutical and non-pharmaceutical interventions to further document the true potential of DCIs. I thank you for your attention, and I pass on to Jean-Michel Josselin, who will be commenting on the work package. Thank you very much, Jean-Michel.
Okay, thank you very much. Do you hear me?
Very well.
Okay, that's perfect. Thank you very much. This seminar is really very fascinating. I think that WP11 deals with a really challenging issue. And it is a two-step process that is involved in it. The first one is, how do we accept discussing DCIs? If we do, then we need to extend the scope of efficiency analysis. Usually, when we discuss northeast, we discuss from a partial equilibrium view. We deal with condition X, with given patients, current potential. But if we want to extend to DCIs, then we need to move on to general equilibrium with a variety of conditions, X, Y, Z, and etc. And now the patients, they are not those patients of a given pathology. They are, to quote Dewey, they are rational Rawlsian patients, which involves then the health authority, which is in charge of carrying out the social contract. So I think that in philosophical terms, we move from the narrow view of partial equilibrium, just one market, if you say, to something which is much broader. Second step, having accepted the first one, if we wish to
We lost you, Jean-Michel.
You lost me. So at some point you lost me. Okay, so I'm back again.
At the second step, Jean-Michel.
Okay, the first step is okay. Then after the first one, there is the second one, as Jean-Claude was pointing out quite relevantly. And then to implement the second one, we need to understand the extent to which those health authorities are willing to include Southwest into the choice set. If so, then to what conditions would they select those DCIs? Having said that, the only way to answer those questions is to elicit preferences. And WP11 did that, I think, quite successfully through a discrete choice experiment. And practically, they distinguished between willingness to consider DCIs, shall we include them into the choice set, from the willingness to adopt DCIs. How do we select them within the choice set? Please, next. Sorry to ask, but from my opinion, the choice of the attributes was quite appropriate. So if we go back to what Liz was saying, the central attributes, they are the extent of health loss, reversibility of the loss, extent of cost saving, to which we add sensitivity attributes, disease severity and uncertainty in cost savings. And I think there are a number of very important findings. And my list is not exhaustive, of course, but I think that the first point I want to stress is there is a dilemma which is persisting, which is the choice perspective. This double agency phenomenon that is prevailing throughout health economics is still there. We have the patient's health standpoint. And in that case, what they find is that the health loss reversibility attribute prevails. And then we have the population's health standpoint. And then the cost attribute prevails. This is something that was previously discussed in the fifth working paper, work package, sorry. And this is something which is, I think, quite pervasive throughout health economics. So that's the first finding. The choice perspective is still to be solved. Second finding, significant health losses are not an acceptable prospect. I remember that old article by O'Brien and other colleagues about the selling price of a quality, which seems to be bigger than the buying price of the quality. What remains unclear at this stage is the significance of significant. Are we talking about marginal losses? Are we talking about discrete losses? This is something which remains to be understood and probably also quantified. And also the report rightly stresses that kinked thresholds, they are unethical, okay, but they seem to be resilient. They are pervasive throughout the answers to the DCE. And then, next point and last point, switching back to usual care does matter. That's another very important finding of the study. But there seems to remain a kind of trade-off with a cost-saving item. And also an unanswered question is about why did you do it in the first place? So you decided that less QALYs was better, but then you feel that more QALYs going back to normal is even better. So why did you do it? And switching back from the DCI to the previous situation, of course, is not neutral if we are dealing with a general equilibrium viewpoint. So there are still some bridges to, some gaps to bridge. But anyway, I was really fascinated by what was done with the DC. So thank you very much. That was my comment. I'm back to mute now.
Jean, we can't hear you.
I'm just putting myself off mute, Lise. Thank you very much. So we've got through the formal presentations. We now have a section that's called Impacts, Contributions and Future Agenda. And what I want each work package to do, we'll open it up to questions and answers in a little while, but I want to put each work package on the spot and ask you to give me 3 things in short answers. The first is, what's the practical relevance for decision makers of your research findings? The second is, out of your research findings, what's the one thing panel should be capturing as the future research agenda? And the third thing is, how do we use projects like this to improve EU collaboration? So, Lisa, you're not muted, so let's start with you.
So I was trying to hint at the fact that there was a question that was asked, and I would have wanted to be able to respond by the discussant. If you just give me the 1 minute.
Yeah, absolutely, yeah.
Okay, that would be very nice. And before we move to the more general discussion, I believe there's always been a sort of interaction, all the more that there's only one discussant. And so I just wanted to say that Jean-Michel asked me, why did we do it? And I felt it would be good to give an illustration. And when I was at HAS on the board, we made a recommendation back in 2008, which basically suggested that we should have ACE inhibitors for hypertension as a first line, and then only have ARBs for a second line, and make sure that this is only given to those patients that have side effects. And so I just wanted to give this example. Another example that could be discussed, and that would be an interesting discussion to have, is AstraZeneca compared to others. Is this a decrementally cost-effective intervention? The recent recommendation by HAS that those who've already had COVID should only have 1 injection. All these are indications that decrementally cost-effective interventions are taken every day, but it's under the carpet. And I would much prefer if they were discussed. And I think that's the whole point of the work we're doing. And thank you very much, Jean, for giving me that minute. It really did matter to me. Thank you.
You're very welcome. And now can I, Lisa, ask you to address the 3 key questions that I posed. The first one is, what's the practical relevance of your, I think you've largely covered it, but it's just a way of kind of summarizing the practical relevance of your research findings for decision makers. the one item that you think Panos should include on his future research agenda as a result of your research? And thirdly, how can we use this project to improve and promote European collaboration?
I'll be quick. Relevance. I think, having worked at HAS and chaired the Economics and Public Health Committee, I think what is important is that we give the committees all possible set. And so that's a practical consideration, is giving all possible treatment possibilities, not pre-selecting. So I think that's the practical relevance for definitely HTA committees. The second one, the one item for research agenda, is definitely inquiring, doing exactly the same thing for patients and for population. And in many ways, it comes back to Wolfgang's work with a DCE as well, comparing across the different preferences to try and understand how far they might be. And finally, well, definitely, I think it would be wonderful to be able to work with the different HTA agencies on exactly this topic, which is totally under-researched. We had no idea that Jaime Caro, when he said that we were going into the Wild West, mentioning the Southwest. Oh, certainly, Jaime, you were right. Thank you, Jean.
Thank you. Jaime, since you've been mentioned, let's pass on to you.
Okay, so practical relevance, I hope, is fairly obvious. This provides a direct tool, freely available, with lots of training and information for both HTA agencies and their stakeholders to use to provide very transparent and reviewable models. Item to include in future research, there was one thing that we did not complete in our work package because there was essentially no literature on it, and that is how to make projections of costs. We focused on projections of survival, but projections of costs escaped us, and I think it is an important item and requires further research. And to improve collaboration, I think I want to underscore again the point I made in commentary to Work Package 7, and that is that the discrepancies between regulatory and health technology assessment must be resolved as far as possible. And one way to address this is that we can leverage the DICE approach to create what are called whole disease models or recurrent models. There's various names for them, but the basic idea is, why is everybody creating their own model for their own HTA agency, for their own particular purpose, et cetera? Why don't we leverage these models, have a European repository that allows collaboration among agencies, research teams, and so on, using the same structure, rather than having to worry about differing structures, different assumptions, and so on.
Thank you. Okay, I'm going to let the work package leaders just jump in and have their opportunity to speak. So I'm not going to go through you individually unless nobody speaks, in which case I will. So who would like to comment next?
Can I speak now?
Yeah.
Okay. I think the first point, I will say that our study, our work is very important for research community, and they could benefit for the societal perspective. Also, patients association could use our information of the social cost, caregiver, informal care, and also health technology assessment agency can encourage a strong recommendation for including social perspective. The second point, more areas in the future to work. We are going to work in the cancer area and stroke answer, incorporated the social cost. I think could be very important. And also the third point is just to have the same guidelines and incorporated the social cost in different countries in Europe. I think that's all that I have to say.
Thank you, Julia. That's very brief for you. Okay, who next?
Yeah, I'm happy to go next. So I think in terms of practical relevance from our work, there are maybe two aspects. One is that there are now, so given the increase in or interest in use of real world evidence, there are lots of simulation studies around. What we're providing is really a very large scale evaluation of the state of evidence of non-randomized studies as it is. So I think that will, I think, help HTA bodies as they go through there and update their methodological guidance to help them shape their thinking around that, rather than only relying on maybe results or findings from simulation studies, which might portray a very sort of optimal and ideal scenario of where non-randomized studies could go in the future. And the other thing is that I think our recommendations would hopefully, as Juan Carlos pointed out in his commentary, be useful to smaller agencies in particular that are not able to draw on very substantial support from academic support units, etc. Again, shaping their own guidance, but also when they encounter non-randomized studies or submissions based on non-randomized studies, to help them shape their thinking. And looking forward in terms of future research, I think there is scope for looking more granularly at, so given that we have these different use cases of non-randomized studies, we have single-arm studies really at the time of market approval for new drugs, which might be very different than sort of large-scale observational studies that might be part of outcome-based reimbursement schemes. So I think there is scope for understanding better the biases inherent for each of those. Yeah, and EU collaboration, well, I would say, but that at least that was a learning for me.
Max, we're not part of the EU, so you don't have to answer that bit if you don't want to.
Oh God, European collaboration, but I think that's not. Is that the message we want to give out, Jean? We can still.
Absolutely not. I voted to stay, so I'm all for staying in and being part of the EU.
Yeah, well, but in any case, I think. For me, what was clear from the work that we've done and the workshops we've had in conversation that there's scope for learning from other countries, and so that it would be a shame not to do that in future projects.
Okay, thank you, Monica.
Some learnings. In working package 7, it was quite clear that there is a lot of variability in decision making. Multiple dimensions are considered. So a key message is that if we want to tackle this type of variability, one of the issues is that committees should have better guidelines, work in much more structured formats. Because, well, variability can be related to many things, but current evaluation processes cannot be audited in a sense of being sure that committees work in a consistent way, that decisions are made a long time in a coherent way. So the way we try to tackle this with the framework is to provide tools that the committees work in much more aligned formats and with guidelines from the agency in more structured ways. So we think that from the case studies we gathered, it has quite a potential. Of course, we need more research to deepen framework, and I see obvious links with other working packages, for example, with package of rare diseases, in which the type of models we are using and the conclusions of working package 10 quite related and require joint work, for example. So that would be my key points.
Okay, thank you very much, Wolfgang.
But Panos may have other points related with working package 7. So
I'll come to Panos in a minute. I'm just going to go to Wolfgang, then Panos, then Karen.
Yeah, thank you. Coming back to work package 5 about preferences on adolescence and child health, I would see the most important practical relevance, of course, with the value sets which are already used. So there is a practical relevance for cost utility in analysis in this area. So I think that's obvious. For the future research, I would see that was also discussed here in the sessions, the transition between the age groups. And that might be that we come up with kind of stepwise adjustment from one age to the other, if we find a magic modeling which brings these different approaches nearer to each other. But I'm not sure whether this will be really successful. We'll see. That's future research. And for the EU collaboration, especially in this project here, I made the experience that it was good to have different countries on the project, and also to have indirectly the contact to the regarding HTA bodies. They sit together from time to time and talk about things, but this is, I think, sometimes more practical, more on approaches or some methods which are already there, not so much about research, which would be something they wished. And so if we as a research group come to them and bring them together in a way that we do not say that there are no differences in the needs in the countries, but that we can include them in our designs, I think that's the best we can do on European level.
Okay, thank you. Panos.
Thanks, thanks, Jean. Lessons to be learned from work package 7 and also from a broader project perspective, but I'll focus on work package 7. I think from a practical relevance perspective, what we have shown is two things. First, that there is a model that captures key elements of benefit as decision makers coming from different perspectives see it. So we have used, I might add, and credit to others within the group that have actually contributed to it, large numbers to capture some of these elements, some of these parameters of benefit that decision makers use. And we've come up with a value framework that captures stakeholder preferences, And I think that's something that decision makers could value significantly across agencies and across settings, whether you are in the European Union or on the periphery, as we seem to be by exiting from a UK perspective, in other words. In terms of the future here, we definitely see a lot of scope in terms of testing what we have created painstakingly, but with the very active collaboration of HTA agencies and insurance organizations. And I explicitly mentioned TLV in Sweden and INAMI of Belgium. They've been extremely helpful, and it was a learning process. But future testing of the same framework across disease areas, different contexts, but also providing a broader stakeholder mix to reflect decision-making processes would be extremely valuable, so we can capture some of the nuances that are needed. I think Aris in his presentation showed the variability in what constitutes value and benefit in two of the case studies that we did. And in terms of the EU collaboration, I think as a continent, we need to make a decision about where we want to go. And definitely, and that the same applies to the assessment of benefit and value in the context of health technology assessment. There's definitely an awful lot to learn from each other, and there's definitely significant opportunity to contextualize whilst having prima facie an assessment what constitutes benefit, clinical benefit, and the acceptability of that benefit at supranational level before coming to some of the contextual considerations that we want to look at. I think from that perspective, this would give us significant advantages, comparative, but also competitive, in terms of research, in terms of innovation, in terms of adapting knowledge to the circumstances that we face. As concerns work package 7, of course, the adaptability is very clear, and we can certainly use the same framework to arrive at broad decisions or broad, let's say, recommendations at European level. But again, this is something that we do not necessarily control, but we can certainly contribute towards as and when the need arises. And we can certainly put it in our, let's say, in our academic consideration to promote somehow. Anyway, if you allow me, towards the end, I will say a few more things about the project as a whole. But these were reflections on WP7.
I will allow you the joy of final comments, Panos. You certainly deserve them. Karen, can we move on to you? And then I'm going to go on to Senior, because I can see that you're still here. So.
Thank you. So in terms of the appraisal framework that is suitable for rare disease treatments, its practical relevance is starting with the country vignettes showing their appraisal processes and adaptations for rare disease treatments. We started doing this for the EU, but we've added in Australia, New Zealand, and now Russia. So these are proving to be very valuable by HTA bodies and all stakeholders. So our aim is to keep those updated, and that's a personal commitment we've made to do that. We've already updated once during the project, and they are available through Orphanet, which is the sort of global rare disease database, which is mainly used by the clinical community. So we think that link is important. And it's interesting because we started our research thinking we were doing research mainly targeted at HTA bodies, and obviously that's what the framework is. But we've actually found that other stakeholders, particularly manufacturers, so industry and patient groups, are keen to have information that helps them provide the best possible evidence. And that led us to do a whole new work stream, which was the development of a patient group submission template. So that was our reflection with communities. So that has very practical relevance, and we're presenting that internationally. The templates have been developed by learning from a range of organizations, including from Australia, Belgium, Netherlands, England. So it's bringing together best practice and putting it out there. But for me, the future step is not so much academic research, but what I would call action policy research. So it's about trying to implement these tools, seeing what the challenges are, and updating the tools, because to me, a tool is only worthwhile if it's kept updated. So that's what I'm keen to do, and what we're doing at the moment is trying to promote the tools and take comments back on them. And then in terms of collaboration, we have an obvious area for collaboration. Obviously, the EC is hopefully finalizing the HTA legislation on collaboration in the EU. And the second priority is orphan medicinal products, cancer being the first. And so we think some of our approaches have relevance for that. So it would be a nuance of the HTA core model, particularly for rare diseases. There is a gap, however, in that collaborative approach, so that the mandatory collaboration will not include post-licensing evidence generation. That's voluntary collaboration. We have developed a network of HTA bodies that are interested in coming together to talk about how we collaborate across countries to collect data to be able to do reappraisal at a later date. That's what our tools support. We've just published a paper including countries like Lithuania and Latvia, and I think it's been one of the things we perhaps haven't talked about so much. Some of the Eastern European countries can really kind of get value out of collaboration. And I think that that could be an area for kind of a future research idea.
Thank you. I was going to call on Senior, but she seems to have disappeared. So, Joanne, are you happy to make a contribution?
I don't know if I will be able to say new things, but yeah, I think that we have, as already mentioned, we have seen that the costing part of economic evaluations is supposed to be not especially complicated and to be quite straightforward, but we have found that there is quite obscure, and it deserves some more methodological analysis. And also, I think the practical part is obvious. We found that it makes no sense for every analyst to make a new estimates of some usual resource items. So to having a kind of accepted cost list that is used by all studies and is promoted on or at least recommended by regulators and decision makers, I think it would make more efficient the process of making cost effectiveness studies and similar economic evaluations. And so this makes sense already at national level. But then if you want to have some kind of collaboration across EU member states, then it makes sense that we have also some international or multi-country database, of course, not just a national one. And well, this is what we have started to do, and we found that it's not easy, but that it is justified to try to go on and not leave it where we have left, because I think this not be very useful if we cannot continue the work we have started.
Okay, thank you. I think, Lutz Maria, you're the last person from a working group who hasn't commented. So do you want to have your few comments in response to my questions?
You said Luz Maria?
Yes.
Yes, Julio has already talked about my work package.
I know, but I just thought because you're here, you did the presentation earlier, you might want the opportunity to add to that, but it's up to you.
Yeah, it's just I completely agree with what Julio said about our contribution of our working package. So in brief, I could say that our practical relevance is related to the importance of including the social perspective in the economics evaluations. And I think that there are a lot of gaps in the literature and a lot of things that should be taken into consideration when in this issue. For example, it's very important to continue the research in other different areas, and other different files, just to get a robust evidence about how the social perspective can change the conclusions and the results. And it's also a future agenda for our specific work package is just to update the data set related to the unit cost of social cost. I mean, the unit costs that are needed when estimated the social cost. So it's very important to update that website in terms of the ability to access that kind of information when economics evaluation or cost of illness studies are applied. Just in brief and add comments that Julio has already said.
Okay, thank you. I think, is there anybody else who wants to make a comment on the questions I posed? Otherwise, we'll open it up to a more general Q&A session. So if you could raise your hand so I can see, or at least turn your video on so I can see. No? Panos, I can't see anybody wanting to ask questions. There are no questions. Does anybody have a question they put in the chat that didn't get answered that they want to ask?
Not that I can see. I think a number of questions were actually captured or answered in the chat.
Yeah.
Anyway.
Yeah.
I mean, there's no harm in finishing a little bit earlier.
Okay,
if there's no questions.
So this is your last chance, anybody.
Okay.
If you've got questions, I'm just checking both screens of pictures. Nobody's put a hand up or turned their video on. So I'd like to say, first of all, I'm amazed how well we kept to time. I just had not anticipated it was going to be this straightforward. I thought by now we were going to be at least an hour behind. So my many congratulations to all of you for being careful with your time, your presentations, and for giving us so much information. I think the amount of research that you've presented today is just incredible. I think it's really impressive what you've all achieved during the 3.5 years. And I think, you know, the piece that was clear to me through it all is that everything you did has basically opened up a new area where more research is needed. So you might have answered one question, but you've opened perhaps a dozen more. And I think that, you know, we do need to ensure that HTA responds to this rapidly changing healthcare environment, because it is changing. COVID has made additional changes necessary. And I think we owe that to patients, to healthcare systems, to the HTA bodies, etc., that we do evolve things. I remember many years ago, a cancer patient, Albert Jovel, said that, you know, HTA had not changed significantly from the years when he worked in it. And I think we do see now an opportunity for real change that reflects the environment we've got. And I can just ask you to all keep working on that. I think, Panos, congratulations for pulling this all together. Amazing piece of work. So really well done you. I think you pulled together a great consortium. You delivered a lot of fantastic work. So, you know, I think that came with probably a few grey hairs in addition to any that you might have had. Yes. Mind you, I probably got way more than you. I do want to say thank you to not just the work package people, but for everybody who's contributed, because I know each of you have engaged either HTA bodies, to patients, to other researchers, etc. And I think everybody deserves a thank you for doing that. I want to say thank you to Hala, because as project coordinator, she's kept us all going and kept us on what we in the UK would say the straight and narrow. So thank you, Hala.
Thank you, Jean.
And my final comment is I hope that the EU, when they look at what you've done with their money, see the great value that they have had in terms of the research that you've provided, and that they do something with it. They don't let this sit on a shelf in an office somewhere. They actually take this and encourage every country to do something with it. Panos, over to you.
Thanks, Jean. I think the congratulations go to the entire research team at the consortium, because that, you know, this is what they've put in terms of research effort over the past 3.5 years. So well done, everyone, for bringing this to a successful conclusion. I just wanted to raise one point, which I think is very important. The project reflected a response to a specific need, and that specific need was voiced, quote unquote, voiced by the EU back in 2016 to enable us to respond with a proposal in 2017. I think, well, we responded, obviously, we produced the results, obviously. This is not a completed agenda, and I think this has been mentioned by many, by most, in fact. So, in other words, there are several things to do, going forward. So the agenda reflected needs back in 2016. I think the world has changed since then quite significantly, and we're having to deal with even more, even greater challenges. So in the meantime, we're having to reflect on not only COVID, obviously, but just before COVID, having to deal with new technologies, paying for cures. So what tools to develop for that, how to deal with digital technologies, and increasingly also the issue around care coordination, patient stratification in the context of population health, and the likely implications of that for health technology assessment and performance measurement in healthcare systems. So the needs of healthcare systems are evolving, the technologies are evolving, and the agenda is becoming more and more interesting, call it complex, call it fascinating. So I think there's definitely a lot of scope to continue. Our research has got, it's not only a research project, it is a project that has a practical, empirical, but also a policy slant. And that is an explicit view, an explicit requirement, if you will, from a Commission's perspective. So we have to see the likely impact. We have to see how our research results can be adapted, can be applied in specific contexts, and so on and so forth. So I think this is important. So in a nutshell, yes, we can kind of congratulate ourselves for reaching a milestone, and that milestone is the completion of a project. But I think from the deliverables themselves, there is a significant need to continue with the research agenda. Whilst in the meantime, we have to address further challenges quote unquote imposed on us by the evolutions in technology and the needs of healthcare systems. What an exciting tone to finish off with, Jean, and everyone else.
Thank you, panelists. Well, I think that's it. I think unless anybody has any final comments to make, I think we probably will call this a halt. Lots of thank yous and so forth in the chat from people who say they found it very interesting. I just would reiterate that all the materials will be available on the HTA IMPACT HTA website, including the recording of this session. And you can reach out to all the researchers via that website. So thank you all very much.
Until next time.
Until next time.
Thank you.
Thank you, Jean, for your moderation.